welcome all after that lunch. What I'm hoping is that you don't have a dumping syndrome with keeping lights on as they are so you can keep away rather than all the blood go down into the stomach and away from the brain and the head and you start sleeping when these presentations are on. But without much ado, I'm going to start the first presentation here. We have Professor Beatrice Moibe-Adey, who is actually doing things what I call the most technical way. You can see her picture there and her slides, and she will be giving her presentation there. Just a bit about who she is. She's the first surgeon, black female surgeon to own a breast cancer surgery and practice across the world. So that's quite an important feat. So just give her a clap of hands for that. And you can see she's a CEO of Peace and Love Hospital. She's been president of quite a number of boards, and an advisory member, and a founding member, and a woman who definitely knows what she's talking about. So I'll give the floor open to her. Hopefully with the tech, it should work out. Thank you. Over to you. Sound.
In the meantime, if I have a mic, I can just tell you about very importantly to tell you a little bit about Beatrice. Dr. Beatrice is the breast consultant who identified that across Africa, especially in Ghana, that young girls at the age of 11 and 12 had breast cancer. Some of the pictures are horrendous. And because the parents thought that it was just some abnormality, probably a little misshaped breast, they did not seek help. And if they did, they would look at local doctors to do it, not clinical doctors, and then it becomes too late. The BAME Health Collaborative and the Caribbean Global Institute have raised money for some of the major surgeries. She has been fighting across the world to change the age where you will have breast cancer assessment mammograms. She believed that you should have mammograms at the age of 29, and then at the age of 35, and then again at the age of 45 onwards, especially in the ethnic minorities. She is certainly a pioneer in her field. She's received a lot of awards all around the world, and I'm so humbled to call her my friend. But this is what you call cancer fighter, cancer specialist, and she's determined that we can do better. So right now I'd like to present Dr. Beatrice Moibe-Adey. Professor Rotimi, could you do an icebreaker while we try to sort this out, please?
I think this this is a time for us to have Trish. Do you want to do your bits?
Yeah, I think that's
we have Trish as one of the speakers. I think she's third or fourth on the list, and I know she doesn't need any slides. Okay? Trish, come on.
Oh, it's working now. Sorry.
Beatrice Yafi,
Okay, great.
the president and founder of President International and the institutions.
Right.
We all know that cancer. Good morning, good afternoon, good evening, distinguished ladies and gentlemen. Let me first thank the organizers of this great event for such a successful event. I want to apologize for my inability to be with you in person, but this is due to some unforeseen circumstances. I bring you warm greetings from the Office of President International, the Otu Foster to the Second Comprehensive Cancer Center of Excellence, and the Peace and Love Hospitals in Ghana. I want to touch on early detection strategies for breast cancer in Ghana to reduce the late-stage diagnosis. My name is Dr. Mrs. Beatrice Yafi Adai, the president and founder of Breast International and the institutions. We all know that cancer is a global problem. And although the world is rightly focused on controlling the spread of the communicable diseases, we are in danger of ignoring the growing burden of cancer in developing countries. And according to WHO, cancers are killing more than HIV/AIDS, tuberculosis, and malaria combined. According to Global CAN, every year, about more than 27,000 new cancer cases are diagnosed in Ghana. And out of that, almost 18,000 die. These are not just figures. They are not just statistical figures. These are our loved ones. These are our mothers, our grandmothers, our sisters and brothers, our friends. And so I want us not to forget about the fact that these cancers are taking the lives of our dear ones. And these are the cases we still see. Our youngest patient was a 13-year-old girl. She is 20 years now, thank God. The male breast cancer is also not left alone. And sometimes our women come so late that you cannot even do much for them. But breast cancer is surrounded by myths and misconceptions that lead to delayed presentation and treatment. The fact that a lot of people still think that breast cancer is not curable, that is by faith, is caused by witchcraft, is a result of a woman's faults and failures, that breast cancer results as a curse on a family, especially when you have more than 2-3 people developing breast cancer in a family. And this might be because of some genetic mutations. A lot of people think that women die from mastectomy. And because of all these negative thoughts, breast cancer is still stigmatized and is still feared. But we should also not forget that women have to overcome a lot of barriers, the lack of awareness, inadequate or bad treatment, the costs involved, distance, lack of counseling, lack of support, poverty, fear, and the stigma. In fact, in a lot of low and middle income countries, we don't have social support systems. Insurance systems are not working to help these women. And I always love this quote from Dr. Martin Luther King Jr. Our lives begin to end the day we become silent about things that matter. And so in the year 2002, Breast Care International and Peace and Love Hospitals were formed to create awareness among the population, to improve diagnosis and treatment, to advocate for acceptable screening and treatment modalities, to increase survival rates, reduce mortality and morbidity, to establish a database for breast cancer through research, training of manpower, paying attention to women's health in general, and to find ways to support needy patients, using breast cancer platform to advocate for other cancers and non-communicable diseases. And we also seek to engage in research into other types of cancers, especially a type of breast cancer where we have a lot of triple negative disease, the effect of environmental impact genetic profiling, and the way forward with the inclusion of high technology and AI. So the model we use is that BCI, Breast International looks at the healthier community, and the Peace and Love hospitals tackle diagnosis, treatment, survivorship, palliative care, and all that. Capacity building is very important. So very often we train doctors, physician assistants, nurse practitioners, especially those who are in the rural communities where we find a lot of our women and where the women normally report. Training workshops for oncology nurses in basic oncology, since we don't have oncology nursing training schools. Oncology is done as a postgraduate course. We've trained community breast health promoters, young ambassadors, oncology training for the media, and peer navigation trainings. The youth is our priority. They need to know, they need to learn from their youthful age. They will help us to educate their parents, their grandparents, the communities, and by the time they grow up, they wouldn't believe that breast cancer is caused by witchcraft. Our strategies to involve opinion leaders, presidents, former presidents, first ladies, and all that matters. We need to involve everyone because breast cancer, for example, is no respect of persons. Distinguished ladies and gentlemen, we are humbled when we receive a tap on the shoulders by present and former heads of state. This is the Peace and Love Hospital based in Kumasi. We have a similar one in Accra. I want to show the new technology for global health tissue diagnosis. This is a research with UC Davis, California, and University of Washington, where they are saying that we can drink wine without the glass. Distinguished ladies and gentlemen, we now have the first prototype in the world of a whole-view instrument at the Peace and Love Hospital in Kumasi. It's the first time this invention has left the inventor's office in the University of Washington, Seattle, to a clinical site. So we have the first machine in the world. And this equipment is able to help us to diagnose breast cancer within 10 minutes. Now we are working on breast cancer, we will soon move to work on prostate cancer and other cancers. We know that diagnosis alone sometimes can take 6 months before you can even start your treatment plan. And so we need to leapfrog, we need to do this better and to shorten the time that the patient has to stay and wait for the results. You know the stress that the woman, the patient, and the caregivers and the relatives always, the family always have to go through. So we have the machine in the biopsy room. You have your patient on the couch, you pick the tissue, you just work on the tissue within some few seconds, and you put it in the equipment, the CoreView instrument, which reads the image. And this image is shown on the desktop, which can be read by any pathologist who has access to the equipment. This has to live from, not only in the low and middle income countries, but in the hard-to-reach areas of the developed countries. In 2022, we launched the first ever Lancet Oncology Commission's report on Sub-Saharan Africa, and this was hosted by Breast Care International with a lot of commissioners. In fact, that report was written by 52 commissioners, 3 lead commissioners, Professor Olua, Professor David Kell, and Dr. Beatrice Yafiada, and with 50% of the commissioners as women and 50% as men, 50% in the African continent and 50% in the diaspora. What we are saying is that we've seen too many reports, too many ways, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking collective action to accelerate cancer control in sub-Saharan Africa. And so we needed to do something. Right after the launch of the report, we came together as a group to take action. And so we have decided to establish the first ever standalone one-stop shop comprehensive cancer center of excellence, which includes an AI hub. This is the Otumfuose, the second comprehensive cancer center of excellence. The first phase is a $10 million project, which includes all cancers and for everyone. The Otumfuose, the second comprehensive cancer center of excellence, is not only for the Ashanti region, it's for, and not only for Ghana, but the West Africa sub-region and for Africa. This is going to help us to improve health tourism, to keep our patients back home and to treat them at home. It's not everybody who can travel outside for treatment when diagnosed with cancer, but if we don't have our own center, then those who can afford treatment will always travel outside. What about the majority of our people who cannot travel outside? So, distinguished ladies and gentlemen, we had a soft cutting ceremony at a 52-acre plot of land. And this is a group of professionals who have come together to make sure this is a success. Our former president, His Excellency John Adekun is our patron. Professor Ohinemba Wachiedi, who is the young man to Otumfuose is liaison. The project is named after His Royal Majesty. Professor Olua, Professor Saifo Hall, Professor Stephen Avery, Bishop Dr. Glover, Dr. Mauricia Ohinemba. We are so grateful, and we want to stress on the importance of early detection. If we are able to detect the disease early, it improves survival rates, it reduces the cost and complexity of treatment, it increases the chances of breast-conserving surgery instead of mastectomy, and it enhances the quality of life for patients. The Ghana's largest breast cancer awareness walk is normally in October, and so these are some of the exceptions. And we want to invite all of you, those who can join us this October. It's on the 10th of October. Please come and let's walk for the cure. It's an event that through which we showcase survivorship and we create more awareness. Just last year, we had more than 35,000 people coming to work for the cure, with friends and survivors from all over the world, professors and scientists from all over the world to come and join us and to create the needed awareness. some of the survivors who were present. What we recommend is to strengthen national control programs, to increase investment in screening and diagnostic services, to expand public education and advocacy, to promote partnerships between governments and non-governmental organizations, between non-governmental organizations and private sector, individuals, philanthropists, and to improve access to affordable treatment. We want every woman battling with breast cancer to survive. And we are always grateful to the role to our survivors for the role that they play in survivorship drives. We believe that when a person lives should not determine whether he or she should survive or die from cancer. Let's all play our parts in this endeavor. Together, we can defeat cancer. Let's help Sub-Saharan Africa and the low and middle-income countries in changing the narrative about cancers. We also want to thank His Royal Majesty Otumfuose II for his support and his initiative, his drive to help us establish the first ever comprehensive cancer center of excellence in Ghana and for the South region. Thank you so much for your attention, and please follow us on our Facebook, our social media platforms, Instagram, Twitter, LinkedIn, YouTube. Thank you.
It's quite interesting just listening to the presentation of breast cancer that some of the cultural, social determinant factors again play quite a lot. If you remember when she was talking about people believing it was a witchcraft, cultural aspect, so it shows that even in disease conditions like cancer, the whole cultural thing we talked about still plays a huge determinant in our cultural systems. Now, is our second speaker ready? Is he on the line? He's not here. Okay, we are going to have.
I'm here.
Trisha.
He's there. Yeah.
Can you hear me?
I think it's.
Can you hear me?
Yeah.
Can you hear me?
One second, they will be working something out.
Okay, we'll have Trisha come up and start.
Can you hear me?
Yes.
If you can hear me, I can hear you too. Just let me know when you want me to start.
Hi, Will. We're trying to set you up on the big screen. It's giving a bit of issues, so just hold on 1 second for us.
All right. Okay.
All right, cheers.
And I'm here to just talk about cancer voices. And that's coming from survivor and conqueror and lived experience perspective. I'm very honored to be here in St. Lucia to share this talk with you. It's very personal to me. Cancer voices are not quiet. They are not fragile. They are not defined by illness. They are voices of courage, equity, advocacy, and transformation. And today, I speak not only as a governance leader or healthcare professional, but as a breast cancer survivor champion. I'm a woman who has lived the journey, and I'm committed to ensuring that others have better, safer, and more equitable experiences than I did. In my World Cancer Research Fund story, I shared the moment I found a lump, the moment when my life paused. I remember saying without any hesitation, take them both
Hey, Will.
off.
Trisha is only there for 5 minutes, so after she's done, you could directly
It
up.
was instinctive. It was survival.
All right.
It was clarity in the middle of chaos. As a healthcare professional, I suddenly became the patient. I had to learn about vulnerability. I had to learn to trust systems I once led. I had to face the loss of my hip-length dreadlocks. I had to face scars and uncertainty. But I also discovered something very powerful. Cancer doesn't silence us, it sharpens us. One of the things that I live with, and so many others guide us, is the fear of recurrence. It is one of the most unspoken realities of this survivorship. It lingers, it whispers, it tries to steal your joy. The fear loses its power when we name it, when we share it, when we build communities that hold us through it. Courage is not the absence of fear. It is choosing to live forward despite it. And every survivor deserves the psychological safety to say, I am afraid, but I'm still here. In one of my interviews, I said, if I can, anyone can. And it's not a slogan, it's a lifeline. For me, community matters. Patient groups matter. Peer support matters. I've shared my journey so far quite publicly on many platforms. And I'm not doing this for visibility.
for connection. It is to remind others that healing is not only medical, it is emotional, it is cultural, and it's communal. Cancer voices become stronger when we speak together. I work in the NHS in the UK. I work in global governance. And I'm involved in the Caribbean diaspora. My work is rooted in equity. And it's not a buzzword. It is a moral obligation for me. For Black and minority ethnic communities, disparities in diagnosis, treatment, pain management, and survivorship outcomes are well documented. Our voices must challenge systems that were not designed with us in mind. And equity is not only about hospitals and policies, it is also about access to dignity. I'm involved in a mastectomy bra and prosthesis project in Trinidad and Tobago. I'm leading on that project. And I see it as important that we sponsor these bras and breast prostheses for these women who have mastectomies and who cannot afford these essential items. Not because survivorship depends on your bank account, because dignity is not optional. Because every
treatment tools. So many times, if you ask the doctor about a disease, what they find important to them is not important to the patient. We might want to say, oh, how is this drug affecting kind of muscle reflex or that? But for the patient says, I just want to walk. And putting the measures that we, the scientists, want and patients are very important. So I wasn't surprised the standing ovation that Trisha got, and she really put forward a very compelling message for anyone in the health. I think we were all moved, and I'm sure Mr. Clifford, you would acknowledge too.
Any questions?
So any questions do we have so far before we move on to the other session? Do we have Will on the line?
Yeah, we do, but let's see if we get questions. We might have to.
Any questions so far? Yes. Professor Jackson.
Well, I'm not too sure if Dr. Ware is still on the line.
Yeah, just go on the question.
Yeah, my question is about genetic screening. Yeah, my question is about availability of genetic screening. On task side, we have a line of
I want to Wilson now.
and it is a strong possibility. So we have
It's the video, so will we be able to connect the video again? Can you connect it?
some of the rest in the gates are also related to prostate cancer. So we must push for it. Thank you. Yeah.
Will, can you hear us?
So I think
Wait a second.
very aligned to what Tricia said about being involved in the trials. And I think it goes the same way that in terms of the various genetic banks that we put together, how we be part of those genetic banks. And I suppose all we can do is appeal to the various biobanks we put together, that they reach out to the community. But I think you also have to flip it the other way.
Will, can you bring up your presentation?
Those facts, because again, another cultural thing we have is, and I say this because when we had a COVID test, and I was actually out there talking about the COVID trials, the question I kept on being asked was how many Black people or Black origin were in the trials. And those two only had about 5 to 8% of people in trials. But when I put the question back to the audience, I said, how many of you would have participated in the trial? No how many times. So it's people asking, yes, we want to be in the trials, but we would not put ourselves forward for the trials. So I think it's very important that we actually get ourselves, community, the health education, everyone who's talking about, get ourselves aware that we go out and put ourselves forward. So I saw that hand, was there a hand there?
I want to record.
Question, one of the long ones is a group.
Is it recording?
It says send a request. I think I had to approve it on my end.
Where's that recording request? No, it's recording, is it? It's recording.
Yes, it's already recording.
Yeah. Right. So you can use this one, but I won't charge. Yeah. But no, take a break, and we've given you some money for the work you've done. So take a break. I'm gonna see it.
It's very hard to be incentivized to want to participate unless we feel the security of knowing that people who represent us are
Shut that
going to
down.
be present at the
Tell me to shut
for
it
us.
It's fun. Yeah. It should be. You should be on live.
To the mistrust in the health system. So you're perfectly right. I'm to feeling that.
John, Will is on the line.
Will's on the line.
Do you want me to introduce him? Hi everyone, I'm really humbled that Dr. Will Nazar Professor of Global Health and Radiation Oncopathology, the founding director of the Global Health Atlas at Harvard and Johns Hopkins, is actually here with us. Well, thank you so much. You are one of the greatest specialists in the field, and what is really nice about it is the fact that you look like me, rather. And so therefore I applaud you for being here. Today we lost Miss King, who was 57-year-old, to colorectal cancer. And I've got a friend who is critical with breast cancer. It is affecting our people. We need to know more. And highlights like you and Dr. Beatrice and the Master Plus. We just want to give you a round of applause. Thank you.
Sorry, man. All right. Can you hear me?
Yes.
Okay, fantastic. All right. No, thank you so much for the honor of inviting me and for being able to participate in this wonderful event. I've always dreamt of participating in this event, so it's really honored to be able to join today and also to speak with my sister Beatrice, from Ghana. So today, I would like to tell you a little bit about the future. I was supposed to talk about cancer innovation. So as you guys are sitting in the room now, you understand that we are in a transition period when artificial intelligence is going to change completely the way that we live. And so when you think about cancer, you want to think about how artificial intelligence is going to change that. And so today I'll talk to you a little bit about, some of the work that has been going on in this area. Before I do that, I always like to start by talking about what we're facing. We are literally facing an epidemic. I mean, we can use a pandemic. We can say it's a pandemic, but that's really what's happening because right now there are over 10 million deaths per year of cancer. The projections are that by 2050, it's going to be worse. And so that's a massive problem to address. But what's also really true is that there's a lot of disparities in terms of access to care. So if you are in London, or you are in Boston, or you are in Ghana, or you are in any of the countries in the Caribbean, so you see that this map that you look here shows different colors. And these colors basically tell you just a snapshot of the challenges of being able to access care just because of where you are born or where you live. And I'll just highlight, obviously Africa, you see that a lot of the African countries, Southeast Asian countries, and the color that shows that, sometimes you may not even have a cancer center in a country. I give you an example in the country of Cameroon, where I was born, they actually don't have a cancer center right now that's functional. So if you have cancer there, you're going to die painful and distressful death. But if you're walking down in Boston, here in the US, you will see, that there are so many hospitals and cancer centers, that are more than what many countries in Africa even have. So that disparity is really big. And some years ago, the BBC did capture this by saying, do US docs have better access to radiotherapy than Nigerians? And this really this unfortunately true answer, but it kind of shows you the depth of the disparities. And so we begin to think about how can we innovate to change that, right, in the era of AI. And so how can you address disparities? How can you make sure that just because of where you are born, you don't have to die because you don't have access to care? And so, we talked about building this cancer center in the cloud. So you think about your favorite cancer center. Imagine if you could put that in the cloud so everybody can access it, just using wherever they live, using technology. So there are really 4 pillars to that: cancer care, cancer outreach, cancer research, and cancer education. To make it comprehensive, you think about in care, you have to think about prevention, diagnosis, treatment, and palliative care and survivorship. If you think about research, there are many things that you can do. Today, I just saw in the news that robots are going to be taking over a lot of labs, so doing most of the research. So you can see AI is already here. Think about education. How we train doctors now is going to be completely different because AI can do a lot of the things that doctors do. And then outreach, you want to make sure that you're reaching everybody, working with governments, policymakers, industry. how can you do that in the era of AI? And I'll just highlight that, the key here is that in your community, you want to bring access to you. We don't have to wait for you to come to a hospital or a cancer center, because often people come in late, right? You come in late if you're waiting for that. And so that's the whole idea of this comprehensive cancer center in the cloud. So where are we? So this actually in 2016, I had IBM visit my lab at Harvard, and that's when we started this whole concept about building this cancer center in the cloud. And, we've been building different pieces of that: care, outreach, research, and education. And now we are really at the point of integrating everything. Actually, I saw some of the initiatives that Dr. Michaelen is doing, and I kind of feel like there's opportunity for collaboration around that. So maybe after the event, we can talk a little bit about how we can collaborate. But these pieces are really thinking about care. So you can think about, you get on your computer, you can have the care access. You can access the cancer, you can access care tele-oncology. So essentially means that you can see a doctor using your computer or your laptop or your phone. You can get a second opinion if you have cancer and you're wondering what to do. You want to get a second opinion. We can do treatment planning, even quality assurance remotely. That's what we are able to do today. And now they are developing agentic AI tools now that basically can actually do a lot of these things. But like I mentioned, outreach is really important. I'm going to skip that for now, but I want to come back to it in a moment. But in terms of research, thinking about clinical trials. So right now we have a platform that provides collaborations for multi-country clinical trials. So it doesn't matter which country you are in, you can participate. So we have many countries in Africa, in Asia, Middle East, and we are continuously growing. So maybe opportunity to grow this with countries in the Caribbean. And then finally, education, Global Oncology University. Like I mentioned, AI is going to change the workforce. So how do you train people today? It's really going to be very different. And so I do want to show in terms of why this can really address disparities. So my sister, Dr. Beatrice, already talked about this initiative that after launching the Lancet Commission in Sub-Saharan Africa, so they are now building this cancer center in Ghana. Really, she's the founding director for that. So we want to take this, connect that. We can actually implement the comprehensive cancer center in the cloud first, while they are building the building itself. We don't have to wait for that, right? So all of these things. So it means that patients in Ghana can already access the same care, that literally can get the kind of access to the same doctors that are, at Harvard or in other parts of the world, the best doctors, through this platform. And then, you can think about another step which we're actually implementing here in the United States is being able to take this to communities, whether it's houses of worship, churches. You can set up a healthcare kiosk there where you can come in and you can be able to navigate, get screening and navigate you to a cancer center if you find that you need that. And a lot of these can extend to Africa as well. I heard somebody talk about the diaspora, how you can turn brain drain. People usually say, okay, now you've left your country, but actually with technology today, this is a good example where most of you are diaspora from the Caribbean, but you are doing a lot of great stuff now back there, but even sitting in your countries, whether it's in London or in the US, you can use technology to be able to do something around this. So in the US, we already started piloting this in churches where you can bring these kind of terminals to churches. And then in terms of the clinical trials, Tanzania, Uganda, South Africa, Nigeria, a number of countries are already participating. It's a growing family where on Saturdays, like tomorrow, we get online and we get to make sure, review all the data, see the patients who are getting access to these trials and making sure that they're getting the same quality as you'd get anywhere in the world. And then finally, I'll talk about the education. So, we're using the Global Oncology University to train people. So this is an example of a lecture, right? So online, but using those partner sites, whether it's in Ghana or it's in Kenya or Tanzania, as places where people can access the practical training. So you can attend all the courses, the didactic online, but you meet the same professors that you get at Oxford or anywhere else, but then you can do your practical training locally. So this is already being used to train tens of thousands of people already using this model. And then finally, I want to mention that, all of this requires money, of course. So thinking about financing. So We actually have launched with Uganda, engaged with Uganda to start this global cancer financing platform. We're planning to launch this June, but Ebola has become an issue, so we're moving that a little bit forward. But this is the way that people can actually participate, using funding to help with screening, using some of the technology that Dr. Beatrice showed in her slides, where you can just take scans now, and using technology, you can get even diagnosis in the cloud. You don't have to, send samples out of the country. All right, so I just want to end there. Hopefully I gave you a little bit of the picture of what's coming. We are really in this big transition right now of what AI can do or the cloud. And so this is something that, so imagine what will be happening. Actually, this September, we're going to be, having an event at Harvard, basically supercharging, the integrated comprehensive cancer center in the cloud, really launching that with different countries. So if your schedule permits, we actually will extend invitations to you to participate. But the key thing here is that we want to make sure that we address disparities so that every person, it doesn't matter where you are born, you can have access to care, the same quality of care that you get anywhere in the world. Thank you so much.
Will,
Yes. Will, do you have a question?
I don't think he did. He's all the way in California, so I think we can, John, just wrap up on Will's behalf, please.
Again, what I just like to encourage us is also look at some of the nuggets again coming from the speaker. There's a little bit of a focus on AI, which I think we will see later on. But the key thing I want to bring out again was community. Was a lot of them coming back to the work they did related to the community, to the churches, to other things. You could start, and this takes on right from when we were talking about social determinants of health education, getting the community involved. Actually, ironically, I think in about another 3 weeks, I'm going to be doing some health screening in the UK, which is on a church that brought me to do some health screening. So I screen the community on their cholesterol levels and their PSA levels. And I intend to do that every year for this particular church community. So I think there's a lot that goes back to us, what we do with the community and how important that is. So I think, again, you can see that thread coming right through to even this particular presentation. So I'd just like us all to appreciate the way certain words and certain threads are coming through. AI is there, culture, community, health education, consistent themes. And I think the other one is let's get involved. Let's not just be bystanders or listen to it, but let's also put ourselves involved. If we want the data for AI to be correct, it's not correct if our data is not in there.
but we have to make sure our data is in the AI space for it to recognize us. Okay? Michael, have we thoughts?
So we're just waiting for Dr. Malik to actually join. He's just having a little problems. We could just tell everyone about some of the scholarships that we have to offer. If you want me to do it, that's fine.
So I think the other speakers we have, get yourselves prepared. Jasmine, you'll soon be in the firing line. Dr. Clifford, you'll soon be on the firing line. Not yet, but get yourself prepared. And I will also be in the firing line too. So
I'll come next to you if the mic's allowed. Okay, I'm really pleased that the director of Dash Bhagat University in India is going to join us. As you know, he's offering free scholarships for pre-med and also for those who need to do the different courses. And he's super excited because it's only for the St. Lucian population who are interested in medical. I'm really pleased about that. I want to thank Global Public Health University for offering scholarships in various courses. I also would like to thank the British Radiology Institute for offering to support training and development for St. Lucians to become radiologists. I am really humbled by all of the outpourings in regards to the different collaboration. So what we will do whilst we're waiting for Dr. Malik, we can go to, is it you, Griffin? Yeah. So we welcome one of the best cardiologists in the world. Yeah. Yeah.
Where is his presentation? Yes, open it.
Yeah. Turn it here and I will get it. We just need you to click on your presentation so I can do the needy bits.
Well said. I'm going to put it on. That's right.
You just change it, right?
Yeah, it's not on yet.
Yeah. That's where it's there.
Where is that?
How do I do that?
We know.
What is it?
Mirror or extend? How do I do that part?
From the menu, same from the menu.
Does anyone know how to do an extend on Apple? Is it Apple? John, we need you here, please. The Apple people.
Yeah, asking you to mirror or extend.
Yeah, Apple's a
Everyone wants to do this.
All right.
Do you want to just send it to me?
You've probably got to send it.
Do you want to take this out and put it in again? Let's see. Push it in.
What is that I give you where you are?
Could you help him then?
No, but that's Apple.
It's an Apple, is it?
Apple.
No problem.
Apple and Windows is just two different.
Welcome.
Anybody here who knows about Apple?
Should we get Jasmine to come and start our presentation?
Yes, please.
And then
Yeah.
Ross, we get them.
Yeah, get Jasmine to do hers.
Is it done? Unless you just email it to me. Why don't you email it to me quickly? And you will be able to go. If you email it to me, it will. Yeah, m.holdermarch@gmail.com. Yes. m.holdermarch@gmail.com. Aaron. I'm good. Just if you email it to me, I'll have it in a second. And I could pull it up. How are you? In the meantime, where's John? John?
Yeah.
This is the representative from the Ministry of Education, Sports and Youth. So give him the ticket to go up on stage and say something, please. No, we need you.
Remember what I said?
Oh, yes. Okay.
So, yes, no, can I give my presentation? Yeah.
No, pause that pause your presentation because of the time lapse. Pause that for a minute.
He's talking about lunch.
Yes, I know.
Just put your email.
So
He's talking about lunch.
yeah, so no, just let's they will have to bear for one more else we will lose out, yeah. That holds the MARCH at where's it at? Yeah, gmail.com. Yeah, is that it? m.holdermarch@gmail. I have made the wrong thing. Right? Send.
Have you got Jasmine's presentation loaded? She sent it to me. She said she sent it to me.
I'll have to look for it, but I haven't seen it, so I'll have to look. You can go up on stage. You can you send it, yeah? Can you introduce him, please? Yeah. Let me see.
Oh, are you introducing me?
I can't see his. You sent it there. You sent it, didn't you? Is it saying send? I can't see. Does that say send? Can you see if that says send?
Yes, I think he sent it.
Is it sent? It's not coming through.
He sent it he sent it today at 10:09. You see, that was why I wanted to go because mine is loaded in. Mine is.
Yeah, but what I'm saying is that you spoke, you haven't done any presentation yet, no. Okay.
You see, because Yasmin's is also going to be sent. She said she sent it to you. So she has an Apple.
Okay. Hold a second. Clifford, is yours there? Can you see send because it hasn't come through?
It's not come through yet. Send it. Oh.
See if it's in your outbox. I've refreshed 3 times. Where's that key? There's a key here.
Yes, it's here.
Send.
Oh.
What?
I'm not connected to the internet.
Ah, that's why.
Yes.
It's global.
Global is the password. Going to
Okay, it's not connected.
Yeah. So do you want us? Who's on the stage? And who is he going to introduce? Okay.
Sorry about that.
Are you on the Wi-Fi?
No.
Should we move on? Yeah. Where's yours?
So should we?
Yeah, Clifford, let's get you up on that in the meantime. Yeah.
So I'm already in the system. Yeah, that's it.
Can I have that? Okay. Rotimi, please. Rotimi. No, tell him don't do that because there's ministers and stuff watching. Don't do the phone. Come down here. I got ministers and stuff watching. It's not good protocol. Okay, guys, we have to make some adjustments. The adjustment is that Clifford is not connected to the internet. We'll get him up on the internet. So now we will have Dr. John Baladeko, and then we will go straight for lunch. Thank you.
Is this on slide on that side? Show what it is. Oh, smashing. Excellent. Okay, so I'm going to quickly give a quick presentation. I was asked to basically talk about next generation diagnostics, a topic very close to my heart. And what we would notice is it's basically transforming medical detection through AI, genomics, and innovation. And I have tried to imbibe innovation. Be very please be happy with the slides. I put a lot of work into these slides. I'm not an IT tech person, but I've tried to really make them really next generation. So next slide, please. Next slide.
Okay, just so.
70%, as we know, 70% of basically diagnostics clinical decisions are based on diagnostics. And what you can start to see is there's a whole revolution that's beginning to influence that. AI-powered imaging, which I'm sure one of the speakers is going to talk about. Point of care. What we start to see with point of care is all the diagnostics, genetics, all those things are now at point of care. They're being brought close to the patients, no longer the labs. It's all being brought close to patients. Liquid biopsy. The good old days, we were doing biopsies of tissue samples. Now we're actually finding that those same tumor samples are in the bloodstream, and we're able to measure what this tumor is actually doing in the bloodstream. So when you hear about liquid biopsy, that's what we're moving to, which is apart from tissue biopsy, okay? And then there's a whole load of genomic diagnostics. And an important thing is look at it. The whole genome can be sequenced under 4 hours. That is what is happening now. These are things that were taking weeks and days and also costing a lot. Now you can get it down to $200 and get your whole genome sequenced. So you can start to see that things are really moving forward. And many of you might have heard this word, and it's even been mentioned today. Tricia mentioned it, precision medicines, where particular drugs are targeted at individuals. The whole market is moving that way. Diagnostics is moving that way to personalized treatment options. Next slide, please. So this captures everything I'll be talking about: genomic testing, point of care, liquid biopsy, and AI. And what you will start to see with the future diagnostics are 3 words: precision, precise, targeted, speed, getting more rapid, and continuity. What many of us are now becoming used to is we're now getting data that's continuous. In the past, many of you would have blood tests, and the blood test would tell us exactly what is happening at that point in time. Now, people are wearing wearables that are giving them data over 24 hours. So it's not just what was my blood pressure at this point in time when I went to see the doctors. if someone comes up and goes, look at my entire 24-hour blood pressure measurements. These are things that we are not even used to. So we have to even start thinking that things have moved from static to continuous. So these are things that we'll start to see the new things that are happening. Precision, speed, and continuity. Next slide, please.
Next slide, please.
There's a big saying that when you want to watch things, follow the money. And what you start to see is look at the liquid biopsy. Liquid biopsy, the market size is $5.5 billion, but it's projected to be in 2034, 20.7 billion. So follow the money. Obviously, that's where the money is. So it's not surprising that liquid biopsy is going to play a big role in the future diagnostics. Next slide, please.
We have a bit of a problem. Just continue, John, whilst we get back to your slide.
Okay, and the 5 top players that we can see there. Now, when you look at liquid biopsy, what you can, is there a slide before this? Yeah, that's it. Okay. Next slide, liquid biopsy. This should be liquid biopsy slide. Next one, please. See the lovely imaging. Tissue biopsy there. This is what we did in the past. Had a tissue there, invasive, single site sampling, static tumor snapshots. That was what we were doing in the past. Liquid biopsy, it's non-invasive. We're looking at the DNA of tumors circulating in the blood over a continuous period of time. And also, we are starting to real-time predictive monitoring. So if you can then imagine, if we can start to look at things over a course of time, we could even start predicting what might happen. So you can start to see that now that we're moving from static to continuous monitoring, our chances of predicting become much higher. So this is now from tissue to liquid, the evolution of diagnostic insight. You can start to see things are really looking bright. Next slide, please. Again, this is what you would start to see, and I'm just mentioning the words so that next time we hear these words, we start to say, this is all future diagnostics. You've got your DNA for your tumor, you can see non-invasive tumor, you can track tumors in the bloodstream. You've got the genetic tests now that are done in 4 hours. And if you can do that, it becomes, look at the sequencing analyzer, how portable it is. These were big, massive machines that were in the past. They're now on site. You can take that on site and it's portable in 4 hours. So the whole diagnostic field has changed, and it's now moving from sequencing to just say, can I predict? People are asking, can I predict a heart attack? Can I predict that a certain person? In the past, we use various biomarkers to say this individual has a potential or a high risk that have a heart attack. But we couldn't really predict that they are going to have a heart attack. And things are now moving to the place where they can actually look at the heart traces, they're able to detect them and possibly predict. But let's see what's happening. Next slide, please. Point of care testing, the technology, this is basically bringing lab-grade diagnostics closer to the patient. And you can start to see when you start to integrate technology in there, it's fantastic. I do a lot of work in the wearable diagnostics, and I'm happy to show you a few slides. So next slide, let's go to the wearable diagnostics. You can see again, follow the money. Look at what's happening. Look at the wearable medical devices going from 48 billion to 100 billion. That tells you what's the future. And many of you know, Apple is trying to get wearables. I just saw something say, start to measure look at your blood pressure on your iPhone. You've got iPhone 6, you can now measure your blood pressure. So you start to look at it, and you've got continuous glucose monitoring, you've got cardiac monitoring, and you can see multi-parameter biosensors. So let's look at another set of slides that I've tried to do. And Jason told you about, I do a lot of experimentation myself, so this is my data, and an individual who is here. So next slide, please. This slide is blood pressure. Look at that. This was, and actually, I'll put it there. Trish, this is Trish's, that's Trish there, wearing a wearable watch there that actually measures her blood pressure and reports consistently. That is Trish's data. So you can see we are able to track Trish's blood pressure all throughout. You've got the systolic, it gives you a range, the average diastolic. And actually, Trish has now told me, Trish, do you mind if I say this? But Trish has now told me that she's able to detect when her hot flushes come up, because her pulse rate and everything goes on this device. So it actually tells her when she's having a hot flush by a continuous wearing wearable. And this is actually where you can start to see where diagnostics is starting to move. Next slide, please. Now, this is my data. This is me looking at my blood glucose level. And here I've used two devices. One is the Libre patch, which many of us know have a nice sense of the patch there. And the HTK was a smart wearable watch. And they were made, it was measuring glucose based on the dilation. And I was just testing it out to see how good it was. But you can see that it was almost very consistent with the Libre. But you can see that it's good, it's there. Although I still have my doubts with some of these watches that say they measure glucose, because if you don't really penetrate the skin, I don't think you get a true good measure of blood glucose. But you can see Apple and the whole range are trying to do a lot of things in there. I kind of believe they have played with some algorithm, because I tried to cheat and I fasted for a particular part of the day, and the watch still gave me a peak where it thought I had breakfast or lunch. So I think they built some algorithms in there that are predictive and are not quite territory, but you can start to see there's development. So now, rather than looking at a blood glucose level at a static point, you can get it there. And many of you know that Libre has got, they've got one where people now eat food, and then they can tell the food that they get the highest glycemic index. So now I walk across the street and say, I don't eat that anymore. It gives me a high glycemic index. I don't eat that anymore because it gives me a high glycemic index. So this is now what people are beginning to use continuous diagnostics and monitoring. Next slide, please. This again is my own average cortisol levels being measured across a 24-hour period. This was not easy because I had to jab myself every hour to get these blood results. Currently, we haven't yet got patches, so I was having to do a finger prick every hour and measure my results in order to give you a nice profile. But you can start to see that instead of looking at your cortisol level at one period of time, I can actually look at what happens to my cortisol over a period of time. And based on this, I was able to spot for 4 days that around midnight, when you are supposed to have the lowest cortisol levels, my cortisol levels were high. And I questioned, why the hell was it high? And then I checked my activity and found that I had played golf in the afternoon. And then realized that my exercise and activity in the day did affect my midnight cortisol levels. But you see, that would not have been picked up if I wasn't continuously monitoring my cortisol levels. So there's a lot of data that you start picking up with continuous monitoring as opposed to a static If I was going for a blood test, people would say, do your blood test at 9 o'clock in the morning or 4 o'clock, and let's just look at those two time points. So we can start to see these devices are going to start to look continuous data. Next slide, please. We've seen the same thing happen with heart rhythm that are detecting atrial fibrillation, sleep monitoring. We see the same thing there, HRV, and also respiratory trends. All of these watches giving us massive amount of data now, every second. Actually, for us as clinicians and pathologists, it's data over. Because you get someone come and say, oh, look at what happened by pulse. It's just changed by 2 beats. And they say, something happened to me there. And I'm going, wow, just 2 beats. It's still normal. But this is actually the challenge we have with that, as you get everybody walking up to me and say, my heart rate, look at my heart rate drops by 10 beats. There's something wrong with me. And then you have to go, wow, it does move the ship. So this is actually a problem that sometimes having all these big gadgets, giving you continuous data, is a challenge for us. But also the opportunity is AI is mopping all of this up. So it's giving us trends, it's giving us baselines. And in the future, will actually probably help us predict stuff. So don't throw the baby in the bathwater out. It's not perfect, but it will probably help us get there better. Next slide, please. Next slide. Again, genomics. You can look at it again. There, $151.6 billion in 2024. Look at what is projected to be in 2034. Follow the money. That's where the innovation is happening. And you can see currently now whole genomic sequencing is done in less than 4 hours. I mean, I was impressed when I actually did my whole genomic sequencing, and it told me stuff that I didn't know that. But you can get that now. Next slide, please. Next slide, please. Again, you can start to see what genomics is going to do for us. The sequencing revolution, we have multi-armed expansion, which is all the protein stuff. When you start putting the sequencing and the protein stuff that we pick from the blood, you throw that into AI, you can imagine what it's going to start to tell us. It's huge. And then you take a liquid biopsies. Basically, we will soon start to target patients with particular diagnostics and the treatment options. And that's the way forward. It looks expensive, but it's probably going to be more cost effective than actually some of the things we do now. I mean, I've just published a paper out which shows some of, and I just, the impression is that people know we have all these great drugs coming onto the market, but there's still about almost a 20 to 30% of population that these drugs don't work in. They don't want them. These are drugs that we've paid a lot of money for, the lipid-lowering treatment, PCSK9 inhibitors, and yet you get 20 to 30% of patients that are still getting less than 30% have less than that LDL reduction that is appropriate. That's like huge monoclonal antibodies that we spend a lot of money on. So there's still, these patients need to have targeted treatment. Next slide, please. So I think this ends my next slide. This is really just to make sure that you can see I've tried to bring everything together. There's the whole biomarker discovery there. It's going to start to tell us what we do. Companion diagnostics, matching therapy to targets, predicting and optimizing response. We're going to have a load of imaging and back to trials. We're talking about trials. Trials are actually properly well designed, but they are moving also from the biomarkers to bedside diagnostics that work directly. Next slide, I believe this is that one more slide, or this is the last one. This is the last one. I knew last slide I thought would capture everything. You can see that for a man of my age, this is innovation. This is progress. This is real progress. But you can see this captures wearables, continuous development, liquid biopsy, companion diagnostics, and genomics. And I believe if you have all this together, you will see the evolution that we're expecting in the diagnostic future. Thank you very much.
That was a whole mouthful. Very response. I guess the young ones did not appreciate what was up there. But I have questions from the audience. I mean, after listening, yes, we don't know.
Thank you very much.
One. One, two.
Thank you so much.
Here I've been told, thinking about health and thinking about.
Hello?
Yes.
Fantastic. Thank you for your amazing talk. AI is definitely. Yeah. Can you hear me?
Yeah.
Okay. Thank you very much for your amazing talk. AI is definitely the way forward, and there's a lot of choice around the wearable technologies out there, and it's just so much of whether it be about heart rate or about sleep. You've got the watches. How do people decide which one do I go for in terms of looking at addiction, whether it be heart disease, diabetes, or just about mental health, well-being? How do we make these choices and make it easier for people to determine which one?
Great. Yeah, I mean, that's a great question. So I think you find quite a lot of these devices that are marketed around. So the first thing that the first acid test is actually which of these devices is registered as a medical device. If they don't cross the threshold of registration as a medical device, then you could almost say whatever information they give is subject, because there's a reason why they haven't crossed the threshold of a medical device. They are then seen as lifestyle tools. So that would be the first thing that I would always ask is your innovation a medical device? If it's not a medical device, then you are as good as all the others. You see, then it just becomes a matter of you probably doing trials and looking, but only take the ones that are approved as medical device for their true scientific integrity. If they're not, they're toys, that they are lifestyle devices. That's the easy way that I would say. It doesn't mean that you don't look at them, and that's what I tend to do. I look at them and they are advancing and working on, but like I said, how I fasted, and then it gave me a glucose spike. And I thought, hang on, but I fasted, it shouldn't be a glucose spike. But yet they had built in some algorithm there to give a glucose spike. So I went back to manufacturers to say, look guys, this is not good. So, hopefully the next one they will bring out will be better. But I think they are the way forward. Someone's going to crack it. And it's best to be addressed with them. But anyone that's not a medical device is subject.
But how do we strike the balance? Bearing in mind, it's like news. people want to get on the market first. So to disrupt that market, they have a question. Thank you, John, for
That's the last
how many
question.
grades are the
Last
There's
question, yeah.
currently a study going where I think being collected from babies aiming to collect many as possible to do with genomics as well. I come from a village, I'm a village boy, and I want to start today taking on my medical path on the side. So I hear you genomics and games and stuff like that, and I'm afraid that you want to make me taller by changing my genes. How are you going to convince me that I should tap into
Oscar, time. We're continuing on time.
Excellent. No, I mean, you're perfectly right. And I think that's the challenge we still have with the mistrust of the health professionals. I would liken this to the same thing like clinical trials. Okay. So first of all, if you look at the genomics, I mean, let's not forget the diagnostics. Put that to one side. The person is even collecting samples. Why would anybody give their samples
Mango.
to genetic
Mango.
Why?
Mango.
Because the first thing that people will say is, I don't want to talk about my data. I don't want them finding about it. So we have to be, would I say, ready to say, yes, use my data. And the way I tend to use it is I actually tend to use AI and say, look, I am sorry.
Mango.
We are not helping the medical system because we are not giving them enough information. So if you want us to be able to treat you properly in the future, please help us have a bank of information in order to address that. If you don't, then I can't treat you appropriately in the future.
Excuse me.
Thank you so very much, Dr. Mahian. Very important. This is like it gives me great pleasure at this time to introduce Dr. Arun Malik from the Deshbaghat University, who will give us an insight into some of the scholarships that are available. It's a pleasure having you with us. Welcome, of course.
Can you hear us?
Yes, I can hear, Doctor, and thank you so much. I think, am I audible? If I can recheck?
Yes.
Oh, thank you. Thank you. Great. First of all, honorable ministers, distinguished guests, government officials, youth leaders, award recipients, ladies and gentlemen, good afternoon. It is a privilege and honor to address this gathering of talented young leaders from across the Caribbean and beyond. Today, I have been asked to speak on the subject that will profoundly shape the future of societies, economies, and quality of life, the future of technology in healthcare. We are living in one of the most transformative periods in human history. Advances that once seemed like science fiction are becoming part of everyday reality. Artificial intelligence can now assist physicians in diagnosing disease. Robotic system can perform highly precise surgeries. Wearable devices can continuously monitor vital signals or signs. And telemedicine allows patients to consult specialists thousands of miles away. So healthcare is no longer confined to hospitals and clinics. So technology is bringing healthcare directly into our homes, our communities, and even into palm of our hands through smartphones and digital applications. The future of healthcare will be driven by five major technologies revolutions. And if you allow me, I can take first artificial intelligence and machine learning. AI has potential to revolutionize medical diagnosis, drug discovery, and patient care. In the coming years, AI system will help healthcare professional identify disease earlier, predict healthcare risk more accurately, and recommend treatment plans. Rather than replacing doctors, AI will empower them to make faster and more informed decisions. So this world is required technology with a precise technology. The COVID-19 pandemic demonstrated the importance of the remote healthcare services. For small island developing states across the Caribbean, telemedicine offers a unique opportunity to bridge geographical barriers and provide access to the specialists that may not be available locally. A patient in St. Lucia, Saint Vincent and the Grenadines, or Dominica can receive expert medical advice from professionals around the world without leaving their country. See where we are, where the world is, where the technology now. Third, precision and personalized medicine. Traditionally, medicine has followed a one size fits all approach. However, advances in genetics and biotechnology are enabling treatments tailored to an individual genetic profile. This means better
Doctor,
outcomes.
Dr. Aaron Malik, I thank you for that. But I know that you wanted to actually be here.
Right.
We have been having some technical issues, and therefore we've been running a bit late in regards to
Right.
that. Can you tell the St. Lucian people about the pre-med collaboration scholarship? And I think that would be great for them to hear it coming from you.
Yes.
And also some of the courses that you're offering online, so that people can know that as a private university in India, you are offering amazing, and you are also based in St. Vincent. Renee,
Desh
our
Bhagat
patron,
University.
is very glad about that.
Right. Thank you so much. Desh Bhagat University Americas, we set up our university last year, 2025, in St. Vincent and the Grenadines. Our group we started in 1972 from India, and now DBU Americas offering program in School of Medicine, School of Yoga, and School of Business. So from this platform, we announce along with the Caribbean Global Institute, we are already tied up with the collaboration, and we announce some scholarships to the student of the St. Lucia, one full funded scholarship, and to the 4 student 50% scholarship to the St. Lucia student who are meritorious. The applications are available. They can send their application with the help of Caribbean Global Institute. We welcome the students, and the dream will come true for the student who are looking to become doctor. Thank you so much. Thank you so much, doctor.
Thank you. Can I ask before you go, because we're all very hungry going on a break, when are you coming to St. Lucia?
Well, this month, and I will I can plan. You just need your invitation. I'm very much eager to visit St. Lucia. This time I missed it, but definitely I'm very much eager to visit St. Lucia.
Okay, on behalf of the Caribbean Global Institute, the Caribbean Global Awards brand, we've got our patron here, who is Dr. Clifford Thomas, and he's here with us. We're very honored to have our patron, and he is a cardiologist, and he's our patron. And I am sure he's very pleased that you are offering this on behalf of the Caribbean Global Institute. Say something.
No, thank you so much, doctor. And this is a very good opportunity for the aspirants who are looking for, to study medicine. And DBU Americas welcome for those students who are eager and who want to build their career and opportunities with Desh Bhagat University.
So the next generation is where we want to put all our efforts, and teaching,
right,
and education, and giving them the opportunity to get that training is something that we are very grateful for. Thank you very much.
Right. Thank you, sir.
Thank you.
Thank you, madam.
Have a good evening, and we see you soon. Thank you.
Yes, yeah. Bye.
Bye. Thank you. I think there's a time for a break, and then Dr. Clifford Thomas will be presenting to us. So thank you. Have a nice lunch. Please grab your lunch in under 20 minutes, please. Thank you. Neil? Can you pause the recording?
Well, good afternoon, and welcome back. We do hope you had a lovely month. Meeting and well prepared. One of the things we would like to ask of you, as John said, if we see you nodding up, you'll get somebody nudging you. Wake up, because after lunch, we all tend to go have a nap there. We are here from America, New York, and I'm from the United Kingdom. And so what we're about, the reason we're standing up here, no, we're not going to dance. Because I can see the look in your faces, and we're not going to sing.
That's right.
Yeah, so over to you.
Yes, we wanted to take this moment to give our heartfelt thanks to the Solution Government for allowing us and giving us the space and availability of this lovely space today and hosting us to do this conference for the next 2 days, welcoming those youth that have performed extremely well, be able to have an awards celebration to celebrate them tomorrow. So let's just take a moment out and thank the Solution Government.
I'm looking forward to that. In addition to the space, what we have, the water, the food, the meals, we've also supplied the Solution Government, for which we're thanking it for.
Yes.
Well, I think one of the things the government did in life is when you look after people, will come back. Yeah, so we'll be back. So thank you. And again, thank you to the audience. We'll be going into the afternoon session now. And before then, I found a pen. Whose pen is this? It's you. I was going to give it. All right, thank you. Thank you.
Is Clifford about? Yes, he is. Yeah. Thank you.
Yeah, Clifford is from Trinidad. So the flew in Trinidad. Many of you will be here that I have met Clifford. If you think I have met Clifford before today, raise up your hands. There are 5 people. Clifford's surname is Clifford Thomas. Are there lots of doubting Thomases in that house? Right. I'm not going to read Clifford's biography, but just to tell you that he's a gentleman to start with, who is a world-renowned cardiologist. He looks after people's hearts, and not just in Trinidad, it's a global thing. With the power of telemedicine, Clifford is able to give advice, to give second opinion in terms of what treatment intervention a patient should receive. But we're now in the age of technology, where AI and other emerging technologies are becoming prominent. And even though I'm not going to tell you Clifford's age, but there's something about him, I don't know what he eats.
Distinguished.
Makes him look so young and Distinguished.
Distinguished.
So he's going to speak to us about you. Clifford. So welcome. Thank you for coming over.
Thank you very much.
I know Professor Oscar Ocho is smiling.
Good evening, everyone. So I will answer the question. My full name is Clifford Nami Thomas. I was asked how old I was. What is the Independence Day of Nigeria? October 1. I was born on the 1st of October, 1960.
Oh.
My full name is Clifford Nambi. Yes. At the time, my father did believe that there were colonies who were daring to think of becoming independent, as Nambi Kisikwe did at that time. And that was the day that I was born. So you have got my age.
Can you get someone to take pictures?
So I'm here to talk
Tell Anthony, I need pictures.
about digital.
Oh, he is.
The heart of sovereignty. That's why
Oh, I need pictures.
That's right.
That's right. I have planned to talk about recent advances, slide and healthcare platform. Oh, there you go. And in a 2021 review, McGuinness et al. Discussed the promise of digital health and AI. It has evolved with revolutionary advances and a number of developments, and these developments promise to drive early diagnosis and interventions, improve outcomes, and support more engaged patients. That's right. We may be familiar with some of the key aspects of digital transformation. Administrative automation, cloud computing, just to name a few. You can see that extensive list there. Next slide. Go back one, thank you. Go back one. And cloud computing allows electronic health records and tax data to be accessible anywhere, anytime. Because of the ability of cloud computing, you can do scheduling for anyone, anywhere from wherever they are. You can go on our electronic health records and input, analyze the data, and you can look at our images on our PAC systems. And that's the power of cloud computing. So we have got secure, efficient information sharing that gives us enhanced coordinated care and improved data management. So, electronic health records are an essential aspect of digital transformation. Traditional paper-based records are replaced by EHRs, allowing seamless access to information across all departments and reducing errors and improving documentation. So, picture archival and communication systems, PACS are pretty useful in radiology and cardiology, and that's one that's transformed my practice. Right? So we can have data from the EHR, imaging data from the PACS, and we're looking at all of that together. Next slide.
It also facilitates telemedicine and virtual care. Right? And wearable technology, which is good about. Right? Artificial intelligence and machine learning have revolutionized digital transformation. And we heard about AI, machine learning, deep learning, and this is all part of the artificial intelligence spectrum. And all these things, next slide, have resulted in numerous benefits to healthcare delivery. Enhanced patient engagement, efficient healthcare analysis, improved care to patients, more timely assistance, eliminating errors, just to name a few. That's it. But because we have got so many people talking about this, I'm going to talk about something else. Because in my 30 years as a cardiologist, I have heard the sound of the thumping heartbeat a billion times. But we might be only hearing 1% of what it is trying to tell us. We think we are digitizing healthcare. We buy software to automate administrative, clinical, and financial tasks, such as scheduling, medical records, and billing. But the complete clinical story of the patient stays locked in silence. Unfortunately, we are losing or misinterpreting important data signals, not due to lack of faith, but due to fragmented diagnostic capacity. So let's go beyond what we have been doing and visualize where we can go. Let's go beyond digital adoption and talk about sovereignty. Go back. Please go back. Please go back. Sovereignty. One more. The right to harness all our data into the world's most sophisticated reasoning engine, empowering our physicians to provide the best care for our patients. We want to talk about health, data, and the people who depend on it, patients and the healthcare professionals. Slide. So data and technology are at the center of digital transformation. But there is an administrative gap where documentation displaces diagnosis. We remain stuck on the second floor with data donut and missing the human connection. Slide. We move through the clinician to reclaim authority over the diagnostic narrative. You see, we have to go beyond just digital transformation. So that centers around technology toward what we are proposing, clinical sovereignty. A paradigm where the clinician claims authority over the diagnostic narrative. Because technology must serve the healer, not replace the healer. Next slide. So, we hypothesize that the fragmented diagnostic capacity could be addressed in 3 steps on a unified clinical canvas. Here you could see the problem is that the data silos with critical information trapped in disconnected systems and visible to clinicians at point of care. Broken flow of disconnected diagnostic pathways
forcing clinicians to reconstruct context manually. And that is the last narrative, where the patient's clinical story is fragmented across platforms, eroding diagnostic continuity. So, the 3 steps, next slide. That we're talking about. On a unified clinical canvas. Just imagine all the data from evidence to sovereignty, building the status of clinical excellence through integrated diagnostics, unified data, and empowered decision making. Yeah. And these 3 steps, coupled with an innovative colleague, which we call intelligent analysis, IA, not AI, would augment our reasoning capacity. The intelligent analysis colleague would synthesize complex data into actionable insights alongside the physician. And it's a partnership, not a replacement, preserving the sacred clinician-patient relationship while eliminating diagnostic fragmentation. Now, next slide, the legacy is regional evidence and a global imperative. Can we have the next slide, please?
That's a second.
Regional evidence, leveraging cardiovascular research for the global African diaspora. Global imperative, building an enduring scientific legacy rooted in Peruvian intelligence. Next slide. So we are looking at a borderless digital sandbox where shared data engages scientific collaboration and creates shared intelligence. Next slide. We went too far.
Let's go back.
And according to my colleagues, this is liberating. My cardiology resident, Dr. Martina Rodriguez. For years, she said, I felt trapped in administrative workflows, disconnected from my patients. The unified clinical canvas restored my ability to see the whole person, not just fragmented data points. I'm a clinician with my cardiologist colleague, Dr. Gonzalez. This isn't digital transformation, it's clinical liberation. We finally own our narrative and our data serves us, not the other way around. Slide. So, we imagine the voices of my empowered colleagues scale across our transatlantic network that formerly unfairly traded data and natural resources, but now proudly trades data and intelligence, providing insight into the new frontiers. The collaboration creates a borderless digital sandbox, breaking down geographic barriers to unite the world's leading cardiologists, researchers, and institutions in a shared digital ecosystem where groundbreaking discoveries transcend borders. Right? So, data and clinical evidence shared across a global network, transforming global insights into local breakthroughs. Next slide. This is the Renaissance. Next slide. Atlantic International Rescue. Right, next slide. We have accepted the challenge to build a novel digital workspace. Our mission is to eradicate global healthcare inequality by providing faster, safer, and more accurate insights on our innovative platform. Slide. This is our core team. Jacob Thomas, Jacob N. Thomas, CEO, Amoy Bangalore, CEO, David Bruno, Technical Director. Slide. Join the movement. Thank you.
Wow. Ocho.
There you go.
Yeah, thank you, Thomas, for taking us
Yeah, that's a, is she here?
Yeah, she's there.
Let her go up. Yeah. You
introduce
Yeah.
and what future holds for us. I'm sure there are burning questions for you. If you remain here, do we have questions for Dr. Peter Thomas? Thank you so much for a wonderful presentation, very insightful in thought of future. Questions, please? Keep the name and before you come on.
So, Dr. John Bolodero from the UK. So, I think this week for my digital stuff, I heard about a digital stethoscope. I'm sure you probably heard it. And it was one that they heard all these sounds and stuff. What's your views about it? Because of my love for digital stuff, I saw that.
Bring her on next. She doesn't need slides or anything.
And it was a training going on. But I got asked about wearing it. What are your views about digital device? So we
You do her UK question.
and then I'm happy.
So how many questions?
Patient to be lying down on the bed. So Ecuador, Rwanda, a remote area, and the person, not a fully trained cardiologist, is listening to something. And this woman, I think this is XYZ. Gosh, but I don't have that expertise. I'm going to need to have to send to another town 100 miles away to see a cardiologist to do that. And what's that cardiologist going to do? Ask the same questions, perform the same examinations, and place the same stethoscope. Could I take this and put this on you? I'm connected to the internet. I can see the doctor. What are you hearing here? Well, no, that is systolic murmur. And you place it at the apex, it's loudest at the apex. What about the axilla? It's really getting to the axilla. It's blowing. Breathing around. It's loud in expiration. My goodness, that's mitral regurgitation. Do you have echo V-scan probe that you can place there? Connected to your smartphone? Place it at the apex there. A little to the left, a little to the right. Put the color on. Yes, I can see the jet. It's mitral regurgitation. It's severe. The ejection fraction is a bit low. We're going to need some further intervention here. That's where we're going.
Thank you for that question.
Thank you. Give a round of applause, please.
You're right. With a lot of skills, people you hear me still feel what is value. Yeah, so point.
Go ahead, Jasmine. Professor Rotimi, Mike. Go up on the stage, Jazz. She had to introduce her friend doctor, with to speak. It's on off, yeah.
Good afternoon, everyone. Yasmin Leon's consultant contribution and the local submission needs to be here.
Woo!
But more importantly, wanted to introduce the foreign solution, somebody that is proud of to be here. And
when we finish
Dr. Tanya Vestan-Bogner.
We should bring that, put it in the back there. Let's bring that, put the table down. Finish it. We only have 4 more seconds.
She's a physician, and she specializes in functional integrated metabolic medicine, women's health. She's a speaker, she's an author, she does so many things, and she's just had a book, Held and Healed, which is out. I'm actually going to be purchasing a copy. Not out yet, but it will be out very soon, she says. So we look forward to your talk. Welcome, and it's something for you to be there. Welcome, Karen.
So I'm not one to do these kind of presentations, especially on Friday afternoon, so everybody's done. Everybody's done that. We've been running late, we're watching our watches and everything, stand up and just move, get some energy going. I'm sure the Commonwealth is happy to see us doing that. And am I right in saying that just 10 sports in fact, we are blood sugars? 10 to 20 squats after a meal, you can actually drop your blood sugar. This is not a squat. This is a squat. This is a squat. So we just do 10 squats and sit down. Now that I've kind of open up your body, shake your hands, shake. Shake the energy off, because honestly, I can't imagine what the organizers will be feeling now. Yeah? All right. So I'm here to talk about functional and integrative medicine and how I see it as the future of medicine. But what I see really is that it's not a future, it's going back to the medicine that we
and I went in as an 18-year-old, very green, but I had this dream to change healthcare and to truly heal people. And I'm sure those of you in the healthcare field, that's what you all wanted. But instead, we've been taught to focus on disease management. And we were told that we take a history, so those of you who are trained in the thing, soap, right? You take a history and you do the usual, and honestly, I still do that. But beyond the history, which follows a particular way that we've been taught, then you do the clinical exam, you do the past medical history and everything like that. What happens to the person sitting in front of me? So let me just give you a scenario. So just last week, 2 patients came in to me, both in their 50s. Yeah, 2 in their 50s, both female. Typical West Indian woman, we have little belly, we have little baba and weight, And they're frustrated because they've come in because they've been told that their labs are normal. And that it's just a matter of aging, or it's just you're just getting old, or it's just menopause, or you just have to live with it, there's nothing wrong with you, or worse, it's in your head. And then I saw them, got some history and did some more
looked at their labs, and I want to give you a little bit more about functional medicine, but I looked at their labs. One had severe insulin resistance. Insulin was never checked. Her blood sugar was normal, but not checked. So she was not even pre-diabetic, just insulin resistance. She wasn't sleeping, she was on HRT, because whoever had seen her assumed a woman of that age with the symptoms she's producing must be menopause, so she was given a standard prescription and sent on her merry way. And she didn't feel significantly better. So she had insulin resistance. The second patient, insulin was normal, or borderline normal, but she had cortisol dysregulation. She was burnout. We're not trained to identify burnout in our patients. You know, I think then it used to be you have a nervous breakdown, or that's what they used to say. There is a clinical term for it. It's HPA axis dysregulation. And it is far more common, and I would dare to say 50% of us in here have it now or have had it in the past 5 years, especially since COVID, if we're all in the healthcare field. So the point I'm making is that I think the future of medicine is that we go back to where we used to be before we had technology in a sense. I'm not anti-technology. What I am saying is that despite the advances in technology, we are still seeing the high levels of chronic disease. Our numbers have not shifted in the Caribbean. We're still at 60 to 70% chronic disease levels. Why? And we have all the technology. We have digital stethoscopes that can listen to your heart and diagnose it like whatever. Right? Why do we still have high levels of chronic disease? So my personal take is that we need to look at the patient and each person that comes in front of you and go back and see beyond their symptoms. Look at the people in their eyes. The eyes tell you so much. They tell you so much because I don't know about you, but my patients lie to me all the time. Are you taking your medication? Yes. Yeah, okay. Took it today? No, I forgot. Took it yesterday? Maybe. Okay. Took it last week? No, to be honest, I take it when I feel like. Okay, now we get somewhere. When last you filled out your prescription? Because the last time I know I wrote a prescription for you for 4 months was 8 months ago. So what happened to that 4-month prescription? If you still have medication, have you seen somebody else? I don't have a problem. But what do you do with your medication? Because they went on Dr. Google and they found some side effects that they did not want to have. They weren't experiencing, but they did not want to have it, so they stopped the medication. And when they feel maybe the pressure is going up because they feel a little something behind their head, they'll take it. So they lie. When you look them in the eye, you see the eyes, they can't look you back. That's when I know something else is wrong. Or they come in and they say, I'm fine. I am so done with patients being fine. Because you will not pay your money to come and sit in my office if you are fine. So what is the answer? I think we go back to basics. So when I left St. Lucia in 2015 to study this thing called functional medicine, my colleagues thought I was having a midlife crisis. And that I was crazy. But I was a female of that age, so it fit the box of crazy midlife crisis woman. And one of them stopped me and said, why don't you go, if you're going to leave your established practice, and I have this wonderful clinic. And they couldn't understand why I was leaving it. But I felt that after 20 years of practice, all I was doing was writing prescriptions for the same people all the time and not getting to the root cause. And then there are 2 things that changed the course of my career and my life, really. One, I was on the other end of the stethoscope. Any of you been a patient?
Yes.
Yes. Right? So my colleagues are looking at me. I know what's happening in my body. I'm wearing 2 hats, patient and doctor, and I'm trying to explain to them that I need this. Nobody has touched me. The blood pressure was taken by a monitor, so was the pulse. I was hooked up to the monitor. A stethoscope was placed on my chest, but you know, you look at, you're listening, but you're not really looking at it. And nobody looked at me, and I was begging to be seen. I was begging for somebody to look me in the eye because I really thought I was going to die that day. And honestly, if I hadn't spoken up for myself, I could have ended up in a crisis. Because what was happening was that I had a form of asthma that was not the norm. But of course, if anybody's going to have an abnormal presentation, it's going to be a doctor, right? So I had this abnormal presentation. I was late 30s. I was female. So of course, I got that look. You know, when you've ticked off all the boxes and you've given the medication that Big Pharma tells you fits that set of symptoms and the patient doesn't get better, so guess what the problem is? The patient. So I got that look. I looked at them, I thought, these guys are going to kill me. And then I felt a deep sense of shame because I too had looked at patients that way. I realized it. I owned it. I had looked at patients that way. And I vowed then that one, the only person who could heal me was me. And two, I was never, ever going to look at a patient that way again. Never. And I prayed God that I had. And the second thing that happened that changed it for me was I was on the bedside of a patient who was going to die. And I had seen him, he could have been a patient for 15 years. And all I had ever done, we'd see each other in the labs, we do the examination, we talk about family, we talk about how you're doing, and write a prescription. He may have had surgery and seen a specialist, they changed the medication. As a good old GP, I just follow the rules and I write a prescription. But when the time came and he knew his time was up, he called for me. And I looked at him and I said, we're not going to the hospital, are we? He says, no. I said, okay, so this is going to happen at home. I told the family, we're going to leave him home. He doesn't want to go to the hospital, we're going to honor his wishes. Because he and I both knew what was going to happen. The family was probably in denial, but I knew. And we made it comfortable, and we, you know, we're all Catholics, we called the priest, we got last rites, and we did everything. And then I found his feet were cold. So I'm like, let's cover his feet with socks. But then I thought, hey, do I really want to die with socks on? I want some freedom. So I said, let's just massage his feet. Cover it with a blanket, let's massage it. And as I'm massaging his feet, and he look up and he's looking down at me with this look that says, I'm loved. I'm deeply loved because his family is around him. I'm massaging one foot, his daughter is massaging the other foot. And here we are, just prescribing love. And I looked up and saw his face, and that look spoke volumes. It meant to me that he felt seen, and he felt loved, and he was going to die knowing that. And I have not looked at death in any way since then, any negative way. Because if we can prescribe love towards the end of somebody's life, what better prescription can we do? That's the most we can do. So these two things changed the trajectory of my career. And I went into functional medicine because functional medicine is what saved my life. So you're going to ask me, what is functional medicine? So functional medicine is what you will hear: precision medicine, personalized medicine, lifestyle medicine. Some people think it's concierge, but it's not. It is science-based with doctors out there who in their minds, they're looking at them thinking, I'm good about this functional medicine thing, but I'm not sure about it because some sites say it's not scientific. We are science-based, and two, we are at least 10 years ahead of conventional medicine in certain management protocols. So you see PCOS that went into PMOS and they made such a huge fuss. We've been saying that PCOS is a lifestyle disease for about 15 years and treating it as such. It's not hormonal, it's a lifestyle. It's metabolic. And those of you who are from the Caribbean, I want to pay homage to Dr. Martin Didier, who's no longer with us. who introduced the concept of metabolic syndrome to me. I guess I'm a little old because I never heard about it in medical school. But when he told me about it, something clicked. I saw at least 80% of my patients reflected in that chart. And I thought, okay, so this is what it is. So we look at hormonal health, metabolic health, nervous system health, and we also look at the emotional and psychosocial health of the patient. So it's personalized. We look at what is happening to this patient at this time, and at what has brought this patient in front of me at this very moment. What would make them come? My first question is, what brings you here? And how did you find me? Because it usually gives me some, if they find me on social media, they were searching for something. And something I said resonated with them. So it is deeply personalized, it is science-based, and it is individualized, where we'll also look at genomics, the genetic predisposition to certain disease. And I'm here to say that you don't have to express the genes. We look at family history, same things you look at, but we look at it in a more holistic way and also individualized. Why do you have this? Because 5 of us can be exposed. We can all have the genetic predisposition to diabetes, lifestyle, probably eating similar types of foods, maybe exercising a little different. And yet, 3 of us will come out with full-blown diabetes. Why? What happened to the other 2? So you don't have to fully express what is genetically, what you're genetically predisposed to. So why I think it's the future is that, 1, patients are demanding personalized care. They no longer wish to be cookie cutter in anything, and they want it now. They don't want cookie cutter medicine anymore. Because if you don't follow the pattern, they go in on Dr. TikTok, and Dr. TikTok is going to tell them what they want. And usually what Dr. TikTok tells them is kind of out of the charts, so they then have to come and get fixed. So we want to give them and meet them where they are. So I'm urging you to, 1, always meet your patients where you are. So with all of this, does technology come into this? Because I'm seeing Mr. Media have looking at me and saying, where's technology? I'm the tech guy. So yes, his product is very good and we have to talk about something new. But technology has come in where patients can now schedule their own appointments at 3 a.m. if they decide to. They have wearables. This is my Oura Ring. I do not go anywhere without it. The only time it is off is the 5 minutes it takes to charge. It tells me when I'm going to be sick, and it tells me, you sure your major signs are straight. The first time it told me that, I'm like, sure, I feel fine. Well, 48 hours later, I was down with the flu. And I was like, okay, then maybe I should have paid attention to you a little more. So now it tells me when my HRV, heart rate variability, is off, and I know I need to pace myself. It tells me if my pulse is more rapid. It calls me out for eating too late at night. If I snack, it calls me out every single morning. I do it because my heart rate will drop, and it will tell me because I ate. Could you have eaten too late at night? I'm like, oh, you called me out again. All right? It tells me, it will alert me if certain things are wrong. And if you think it's not science, I believe in it. And the reason I believe in it is that there was a patient who came to me and told me he was very fit, ate exceptionally well, ran every day. Lean, muscular, in his 60s, early 60s. And he came to me, and the reason he came was because his Oura Ring told him that his body temperature had been running under his norm for the past 4 weeks. I'm like, okay. I said, okay, well, we meet the patient where they are. He tells me this, I'm going to take him seriously. It turned out he had cancer. He was dead within 8 weeks. Well, guess who went and bought an Oura Ring before me? I went and I got mine. I'm like, this picked us up. So although we weren't able to save him, we were able to give him the 6 weeks he needed to put his affairs in order, to bond with his daughter, and to do whatever he needed, say, make amends with whatever he needed to, and, just bond with his family the way he needed to. So, this is where we're going. Wearables, Apple Watch. I think now, one of these wearables can actually check your blood pressure. I'm not sure how reliable it is. I want to test it out because I'm usually the first guinea pig. Anything I tell you to do, I've done it. Anything I prescribe, I've done it. So I'm usually the first guinea pig. So this is where we're going, wearables. And I want the data coming into me. So you log in to a portal, the data comes, it flags it, I call you up and I said, the pressure has been rising. I need to see you. I need to see you this week and we schedule the appointment. Because they're not aware of it. They're probably not looking at the data. They're not even looking at the stats. But I'm picking it up. And if my portal will flag the patient to me, which I've set it to do, it's even better. So this is just 2 things we have now. Oura Ring, Apple Watch, Whoop. There's one now that you put on your ear for women, an earring, because it takes the pulse from the earlobe. And I think so far that's it. It's usually variations of the ring, variations of a watch. The earring is fairly new. And am I missing anything? I think the CGMs. So the glucose monitoring is also very, very valuable for me. Even if you're not overtly diabetic, it gives me a pattern. So I tried one and I never realized how much coconut water affected my blood sugar. I'm not diabetic. I had 1 glass of coconut water, very cold, very nice, very refreshing. Gulped it down. An hour later, I'm getting this beep, 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 beep. I'm like, what's going on? And I check it, my blood sugars are off the charts. And the only thing I had was coconut water. I never realized how much it affected me. So it may not do to everybody here, but for me, coconut water is the only if I'm going to do it, I'm going to make sure I have enough protein or something with it to kind of stabilize the blood sugar. So where do we go from here, guys? We're in a sick care model right now. All we do, all patients are trained when you feel unwell, you go to see a doctor. See us by antivirals and those what's going to happen if we continue with this sick care model? Because we have not made a dent in chronic disease in our population. We are very good at saving lives in emergencies, and that's where Western medicine is top tier. We're doing amazing things, robotics, and we're doing all these things. But this is when the patient has already gotten and crossed the line to disease. I put it to you that instead of that, let's try and educate our people from childhood. Let's tell them how to eat, what to eat. Far too many young children are not aware of the local foods. They only know mac and cheese and chow mein, right? You go on the side of the road to buy a meal is rice and peas. I'm sure everybody from the Caribbean will understand. It's rice and peas or chow mein or mac and cheese. Right? Half the container is filled with that. You can barely see the salad. The salad hasn't been sitting there for a while. If their salad is drenched in the most processed salad dressings that you can find, and there's a smidgen of protein. When I tell you to eat more protein, they look at me like I'm crazy. So, 1 minute. So my take from this is, it's not either or. It's not conventional medicine or functional or integrative. It's everything together. It's all of us working together. No one specialty is better than the other. We need to work together as a unified approach to patient care. and also educate our people in preventative care, the importance of coming for their well-person checks from their 20s. We're missing so many things because we're not checking them until they found something. So my take, or what I'm urging you to do, is keep talking to your patients, keep asking their questions, keep looking into their eyes and see the human sitting before you, not a disease.
Thank you. And I want to say thank you for being here. And can you give the St. Lucian? I'm going to speak to Jazz because we have a FemTech roundtable that is happening in October and it's remote. It's for only females, explore females' issues. And I certainly would like to be part of that. Give a round of applause again. We are going to fast track, so because we really want to fast track, and some of us want to go to the beach, so now we're going to have Dr. Alfred Walker, who's going to come online, followed by Dr. Lenny Lomax, and we are going to fast track because some of them are abroad and they're waiting patiently. And I know that Gilbert George, who is from St. Lucia, but is the director.
Yes, I can.
You can hear me. Another Trinidad and Tobago thing? Come on, let's hear it. Wow. I hope that we can see you. You're a little bit low, but that's okay. And you have your presentation. You want me to pull it up?
Could you enable screen sharing, please? Could you allow screen sharing, please? I will pull it up.
But you have that power.
No, it says host has disabled attendee screen sharing.
No. Neil will take care of that. Neil? He has it now. You have it now.
Okay.
Yeah. Could you welcome, before we go any further, this is Dr. Alfredo Eugene Walker. Wow. There's so many letters, but he's a forensic pathologist. So can you give him a round of applause, please?
Okay, thank you very much.
The floor is yours.
Thank you very much. Good afternoon, everyone. I'm grateful for the opportunity to present amongst this distinguished faculty. I am a forensic pathologist, and I hope to bring a slightly different slant to the overall theme of this meeting. So I've chosen a presentation which I've titled The Utility of Forensic Pathology in the Investigation of Perinatal Fatality, to show how forensic pathology and autopsy pathology can be applied with respect to answering significant medical legal questions in the practice of medicine. So these are my learning objectives. By the end of the presentation, you will be able to discuss the spectrum of birth injury, discuss the pathology and clinical effects of cervical spinal birth injury, discuss the public guidelines on operative vaginal delivery by the UK Royal College of Obstetrics and Gynecology, and discuss the utility of medical legal postmortem examinations in the investigation of intrapartal fetal demise. So I have no conflicts, no financial conflicts to disclose, and we will get straight into it. So the case in question relates to a 37-year-old mother who was gravid at 2, para 0+1, who had a normal pregnancy with a normal fetal anomaly scan at 19 weeks gestation. She went into spontaneous onset of labor at 38 weeks gestation at around midnight. She suffered a prolonged second stage of labor with failure to progress as a result of a clinical diagnosis of shoulder dystocia. In the last 10 minutes before the infant was delivered, there was fetal bradycardia on the CTG monitor. The baby was delivered successfully just before 7 hours later at 6:49 a.m. after 4 attempts at forceps. On delivery, the infant was noted to be floppy, gray, pale, and atonic with no detectable pulse or respiratory effort. It was admitted to the neonatal intensive care unit, but unfortunately died the following day, just before 7 p.m. A medical cause of death certificate was issued by the junior doctor on the obstetric team, and that certificate of death gave the cause of death as 1A, hypoxic ischemic encephalopathy, due to 1B, traumatic delivery, in brackets, query tracheal tear, due to 1C, shoulder dystocia. So you have to understand that this case was being signed up without a postmortem examination having occurred. However, on receipt of the medical certificate of death, mother was not happy with the insertion of query tracheal tear on the death certificate, and she claimed that she had not been informed about that possibility by the obstetric team. She then contacted the office of, now His Majesty's Coroner, then Her Majesty's Coroner, who accepted the case for investigation and initiated a medical legal death investigation and asked the police to investigate these circumstances. As part of that medical legal death investigation process, a forensic postmortem was requested, and as is customary in the United Kingdom, based on established protocol and practice, this postmortem examination was required to be performed jointly by both a forensic pathologist, which was myself, and a pediatric pathologist. So in preparation for the performance of this postmortem examination, the delivery notes were reviewed. It was evident that the infant was floppy at birth with a pale gray appearance, with APGAR scores of 0 at 1 and 5 minutes. Resuscitation was instituted with bag and mask, and there was a trial of oral intubation in between. The first attempt at trial of oral intubation occurred at 3 minutes of age using a 3.5 centimeter endotracheal tube, but that was unsuccessful. Resistance was felt as the doctor passed the vocal cords, so the tube was removed. A second attempt was made 3 minutes later, again at 6 minutes of age, with a slightly smaller tube. Now the tube was able to be passed about 1.5 centimeters beyond the vocal cords, but on bagging, the neck started to swell up and there was palpable surgical emphysema. So that tube was removed. A third attempt was made 9 minutes later at age 15 minutes with an even smaller ET tube, but that only resulted with a further increase in the clinically detectable surgical emphysema. At that time, the midwife then contacted the obstetric consultant, and on advice from the obstetric consultant, the infant was successfully intubated by the midwife using a size 8 suction catheter over which she threaded a 3.5 centimeter endotracheal tube. And that occurred at 25 minutes of age. There was good bilateral air entry after that fourth attempt with no further increase in surgical emphysema and bagging. At 35 minutes age, the infant was transferred to the neonatal intensive care unit, where on admission, bruising of the neck and forehead was documented, together with small cuts on either sides of the cheeks, which were attributed to possible forceps injuries. During the 18-hour stay in hospital in the neonatal intensive care unit, the infant developed multiple medical complications. Ultrasonography of the head was performed, which only reported subtle asymmetry of the brain with a lens-shaped hyperechoic area against the left temporal aspect of the skull that was suggestive of an extraaxial hematoma. And eventually, the infant was taken off the ventilator and declared dead. This is the list of abnormal laboratory investigations that were found, which reflected the medical issues that the child suffered. So in preparation for postmortem examination of these cases, it is standard practice in forensic pathology to perform postmortem imaging, and that could be in the form of either plain radiological skeletal survey, plain X-ray of the entire body, postmortem CT scans where those facilities exist, and postmortem MRI if you are quite fortunate to be practicing in heaven. So on skeletal survey, there was apparent elongation of the head with considerable swelling at the occiput. There was overlapping of the sutures, but no skull fracture identified. The bones were deemed to be of normal density with no underlying metabolic bone disease. But on the lateral view of the neck, air was seen down to the level of the larynx, but not past it. And the reporting radiologist stated that that may be a normal postmortem finding, and there was no evidence of airway injury. Also reported was an increase in the prevertebral soft tissues, which was deemed to be either due to laryngeal trauma or bleeding from the cervical spine. Postmortem MRI was also done, and that reflected severe subcutaneous edema, a left parietal extradural hematoma, intraparenchymal hemorrhage of the left cerebellar hemisphere with a small posterior fossa subdural, normal brain structure, and a high signal of the soft tissues of the larynx of uncertain etiology was detected in the neck. Hemorrhage was raised as a possibility. So this is the sagittal views of the MRI. I have pointed out for you the subcutaneous edema in the upper aspect of the film on the left and the posterior fossa subdural on the lower aspect of the right. I don't know if there are any radiologists in the audience, but are there any additional finding in the second film on the right of the slide? Feel free to jump in. If not, just keep it in mind. Coronal views of the MRI show the left cerebellar hemorrhage, as you can see here, and the extradural hemorrhage as reported. There was also evidence of cerebellar hypoxia and acute edema as well. So a post-mortem examination, this was the infant. It was a normally formed neonate. There were no dysmorphic features. The birth weight was 4.265 kilograms, which was big for the expected gestational age. The expected weight should have been 34 grams plus or minus 534. So even at the upper limit, this was a big baby. So this was macrosomic. The head was elongated with a boggy consistency, consistent with what was detected on skeletal survey and MRI. There was flattening of the frontal region with bruising and petechiae. The anterior fontanelle of the head was tense, and there were multiple craniofacial injuries, both patterned and unpatterned, evident. And there were marks of resuscitative medical intervention. So this is the right cheek, which shows an apparent injury. It has a sort of U shape to it, and I would be very much interested in the views of any member of the audience as to what could have caused this injury. No takers, okay.
Forceps? Yeah, that looks like a forceps.
Correct. And on the left cheek, there was a similarly shaped injury that was abrasion. So you have a U-shaped red abrasion with two smaller, nondescript, unpatterned abrasions.
Yeah.
And on the right side of the neck in the submental region, you have extensive bruising. This extensive purple discoloration is bruising with two small superimposed abrasions, and this is the left side of the neck. Again, extensive bruising and abrasions. So if we didn't know better, we would think that this child passed through World War III.
Wow.
Bruising of the top of the head was evident, as you can see here, and on reflection of the scalp after coronal incision, there was extensive subscalp hemorrhage and edematous thickening of the scalp. This is the occipital bone, which has been reflected backwards, and here you can see the posterior fossa subdural. This is the epidural hematoma on one side and on the other side. Layered dissection of the front of the torso was unremarkable, but here you can see that there's extensive hemorrhage within the neck. This is a close-up view of the neck. All this discoloration here, this is blood. So the anterior aspect of the neck is very hemorrhagic, and on removing the anterior neck structures that provided the opportunity to visualize the anterior aspect of the cervical spine, and there was complete dislocated separation of the lower cervical vertebrae as a result of rupture of the intervertebral disc between C6 and C7 vertebrae, through which the cervical segment of the spinal cord was visible. And here it is nicely circled in yellow for you. And as you saw before, there was also associated extensive hemorrhage into the musculature of the neck, with inferior extension into the posterior aspect of the retropleural space in the chest and around the left shoulder joint. The spinal cord was removed using a posterior approach. We could remove the spinal cord either from the front of the body, from the inside, after the neck, chest, and abdominal organs are removed, or we could put the baby in the prone position, face down position, and reflect the skin and subcutaneous tissue of the back and open this vertebral column posteriorly and remove the spinal cord from the back. So I opted to use that approach so as to preserve the dislocated separation of the C6-C7 junction, because had I opened it anteriorly, I would have lost that anatomical finding. So along the spinal canal, there was extradural blood along its entire length and subdural hemorrhage within the lower cervical spine. So here you can see the spinal cord with the spinal durometer around it, and you can see some bleeding. And here, this is the spinal canal. It's hemorrhagic as well. On examining the larynx, there was a 0.5 by 0.4 centimeter horizontal perforation of the anterior aspect of the larynx in the subglottic region. So this is the larynx. It has been opened posteriorly along the posterior incomplete membrane. Bottom of the slide of the photo is left, upper aspect is right, and here the probe, metallic probe, is going through the perforation. And this top right is the fixed specimen, where you can see it more clearly. And bottom right is the histological section prepared from this perforation, where you can see the defect in the laryngeal wall. The heart was of normal anatomy, but so grossly it was okay, but microscopically there was evidence of fresh hemorrhage and early microscopic infarction without an associated infiltrate. So these pink blobs here, these are dead cardiac myocytes. They don't have nuclei, and between them you can see red blood cells. The liver demonstrated properly sited umbilical cord catheters in the umbilical vein and artery, and it imparted a variegated appearance as a result of an admixture of hemorrhage and necrosis of the lower half of the left and right lobe to about 80% of the volume. So here you can see the liver having a non-homogeneous appearance. And this is the histology of the liver, which shows hepatocellular necrosis, death of the hepatocytes. The kidneys, although to you they look very dark and congested, the main finding here is the pallor of the cortices. The cortex, renal cortex, is very pale, but that takes second place to the rather hemorrhagic appearance of the medulla. On histological examination of the kidneys, we can see what we call acute tubular necrosis, which is death of the proximal tubular epithelial cells, which you can get with hypoxic ischemic injury. The adrenal glands had hemorrhage bilaterally within the medulla. I don't have a photo for you. And on examination of the spinal cord, after it was fixed in formalin, it was evident that there was significant crushing of the parenchyma of the spinal cord at the site of rupture at the C6, C7 level. So just to orient these two photos for you, the spinal dura has been opened longitudinally, and the entire spinal cord has been pinned onto a cork board, and it was floated in formalin for fixation. Superiorly, you have the normal, regular diameter of the spinal cord, as well as inferiorly. But in this segment where my cursor is, you can see it's significantly narrowed, and it has a sort of hourglass appearance. The histological slide prepared from a cross-section of that narrowed area just showed the spinal dura, which you can see here. Tracing it out with my cursor, and the peripheral nerves which are coming out. In the center, what is missing is actually the spinal cord itself. And for comparison, this is what a section of a normal spinal cord looks like. So this is the spinal cord, and this is the dura and the nerves. So we have no spinal cord here. The brain was swollen and soft. So grossly, there was evidence of hypoxic ischemic injury, and that was reflected on histological examination. This is a photomicrograph of dead neurons, hypoxic ischemic neurons, which take on a very reddened appearance of their cytoplasm, and they shrink.
Yeah.
The placenta was not available for examination, and in perinatal deaths, the placenta must always be examined, but for some reason the placenta had been discarded by the midwives. So by the time the postmortem examination was requested, it could not be identified for examination.
Dr.
So after
I just want you to wrap up. You coming up to 20 minutes. It's very interesting. I think some of the obstetricians here can't wait to ask you a lot of questions, and so I'll just give you a few minutes to wrap up, please. Thank you.
Okay, thank you. So at the end of the day, This case, that was due to the cervical spinal injury as a result of injuries sustained during instrumentation assisted delivery. And cervical spinal injuries are recognized complication of forceps injury. So that information and opinion was fed back by both myself and the pediatric pathologist to the coroner and through the police, as well as the hospital medical director. But the hospital medical director denied that this injury could have ever occurred as a birth-related event and asked the police officers to come back to myself and the pediatric pathologist to ask us if we can exclude that a third party hadn't somehow entered the hospital as the head was crumbling and fractured the neonate's neck. In the interest of time, I will stop there. Suffice it to say that the long and short was that a second postmortem was performed. It was requested by the hospital and performed, and that second forensic pathologist completely agreed with our findings. So I decided to present this case to show how, had this junior doctor not placed query tracheal tear on the death certificate, no postmortem examination would have occurred, and the true cause of this infant's intrapartum demise would not have been identified.
Wait, before we say anything, Dr. Alfredo, you are in the finalists for the Caribbean Global Awards. And I don't know if you are coming over to London. I hope you are, because
yes,
you
it's
have the chairwoman here, Trisha Zenisa George, and you have the vice chairwoman, Paulette Lewis, MBE here, and you have the chairman himself, for healthcare, who certainly believe that you are, I cannot say, but I just know that it will be a great thing for you to attend. But on another note, I just want to say on behalf of all the clinicians here, as a midwife myself, my God, seeing the Henry's, I mean, I've seen a lot of babies who've died due to all sorts, but to actually forensically see it open in front of me like that, it really makes me realize that sometimes patient safety is compromised. The reality of what goes on when the baby is taken into your arena. It's such an important aspect of medicine. We talk about the living part of medicine, and we celebrate the living part of medicine, but there's another part of medicine that is about learning, it's about giving the right answers, about the criminal element, the civil element. And you're doing an amazing job. On behalf of Caribbean Global Awards, the Caribbean Global Youth Awards, the Caribbean Global Institute, we want to salute you. Could you give him a round of applause, please?
Thank you very much.
I will pass you over to you. I'm sure you know who Professor Rotimi is. And we have St. Lucian Pride and Joy, and I want them to know she's the Pride and Joy, which is Dr. Jasmine Leonce, who is the regional. She's so important to us in regards to obstetrics, maternity. She's a consultant, and she's amazing and humble. She's our pride and joy of the Caribbean, and I'm sure she may have questions for you. Can you give her a round of applause, please?
Ladies and gentlemen,
that is just moving.
Well, I was one of the women, and I'm sure everybody in here was one of the women. And one of the things we don't realize is the potential problems that family.
No, everybody I've been talking to. Next is
Now, I think time will not allow us. The EMI quotation, the duration of the labor, the cadre of the person who undertook the delivery, were they vast at doing managing shoulder dystocia, all sorts of things. That's resulted, even the resuscitation, were they qualified to undertake the resuscitation?
Sorry, I'm having difficulty hearing if it's a question or a statement being made. Could you kindly repeat this?
Statement being made, because we could be here all day today if we were going to break down this case. But like I said,
I tell you what we do, the maternity and obstetric panel that is in August in conjunction with
Mike.
The obstetric panel that we are going to be doing with Lord, with one of the Lords, I don't want to call names at this moment. I think it would be great to invite, to have this so we can see both sides of the coin with Jasmine and a few obstetricians there. This is a real solid obstetric case, and bringing the patient safety element about it, how we handle it. And surely mistakes happen and errors happen, but this, seeing it in this way is very, 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 very traumatizing. And so therefore we were looking at, I just want to say thank you. Can we give you a round of applause?
My pleasure.
Now, I know that Lenny Lomax is waiting in the background. Can you give him co-host, please, Lenny Lomax? Thank you. And after that, we can have a quick call. We are breaking down the presentations to less than 10 minutes. Yeah, less than 10 minutes, because we only, I want to drink a little St. Lucia coconut water. I want to put my foot in the sand, St. Lucia sand. And I want to prepare for the youths tomorrow to make sure that they get all the scholarships they need. Thank you. Is he on? Is he co-host?
Yes, he is.
I can't see him yet.
Hey, hi, Darren McLean. Can you hear me?
Yes, I can.
And did you give me the ability to share screen?
Yes, you can proceed.
And let's see, where is that?
Whilst Dr. Lomax is preparing his stuff, Lenny Lomax is someone I admire very much because he would tell you as the surgeon, he believes in medicine that we can actually start looking at, which is naturally within our reach. So I can't wait to hear his presentation.
McLean, I'm not seeing the ability on your screen here to share my screen. Oh, wait a minute. I see it now. Hold on. All right. Okay, let me know when you can see it.
Yeah, you can see it. Somebody
Okay.
mic on. Can you switch it off, please? Who has the mic on? Please switch it off. Hold a second, Lenny. Someone has the mic. It's on. Can we switch it off, please? Okay, go ahead, Lenny. No, that mic is on.
Okay, can you hear me okay, clearly?
Yeah, just 1 second.
Yeah, there's a big echo.
Yeah, we need volume, just a second.
Okay.
Okay, Lenny.
Okay, well, first of all, Dear Micheline, thank you so much for allowing me to participate. I'm definitely sad that I couldn't be there with you guys. St. Lucia is absolutely beautiful, one of my favorite places on the planet. So good to be with you all virtually. As Micheline was saying, I'm an orthopedic surgeon based in the U.S. for 20 plus years as an orthopod. I've been heavily involved in taking more of a holistic approach to medicine for many years, from plant medicine to advanced technology and precision. Today, I'm going to talk to you a little bit about precision medicine and some specific populations that we deal with. And as I was listening to a few of the speakers a little while ago, this is also relevant to some of the things they were talking about as it relates to more precise and personalized approach to medicine. So we have developed a model that's focused on precision recovery and health optimization, utilizing advanced intelligence. And some of the motivation for that is, obviously being in medicine for many, many years, I've seen the flaws, and it's not necessarily precise, and it's certainly not personalized, as the doctor was saying a few talks ago. And so I think that this should be appreciated, as well, because we have all these chronic diseases. We spend trillions on healthcare, but the outcomes aren't very good. The care is fragmented. It's a one size fits all approach. It's focused on suppression and not necessarily root cause resolution or prevention. And there's no longitudinal intelligence that continuously tracks things and refines and optimizes care, over time. So we've been working on a new paradigm that we're executing here that is focused on precision, personalization, a more holistic approach, and is continuous in nature, using health intelligence and a continuous feedback loop that allows it to get smarter, each cycle. It allows you to further refine the care that's being delivered, for the individual. And when we talk about precision, when we talk about precision, there's some key things that we do, on the front end. And I'll show you an image here in a few slides, which will kind of encapsulate that. So our focus is really building the first human recovery, optimization operating system that combines diagnostics, AI-guided intelligence, targeted regenerative and natural therapeutics, and continuous longitudinal model of monitoring that is in a connected model of care that also includes, virtual telehealth platform. So we don't just focus on identifying the problem, we'll deliver precision guided interventions and tracking the outcomes over time so we can make the care smarter. So this image here will kind of give you a sense of, what we do on the front end, and then as we take a person through a pathway. And so this is a digital representation of the person. And one of the doctors a few talks ahead talked about the auras, the whoops and so forth in this technology that we have. But this is even more comprehensive, where we create a digital representation, digital twin, if you will, or avatar of the individual. So now we could bring all the data into the actual avatar and begin the tracking of this. But on the front end, it's really, really critical to get a comprehensive profile that includes certain biomarkers, genomics, epigenetics, wearables data, health records, the objectives of the person, understanding their social environment as well, their environment as well, and having a complete picture so that way, we can take people down a pathway that is, personalized for them. And then we combine the blood detoxification with, treatment for the brain, as we evaluate the brain thoroughly, in some of the populations we deal with, from the QEEG and brain mapping, so we understand what the current state is, to transcranial focused ultrasound to deliver targeted therapies, to TMS, as well as hyperbaric oxygen therapy. And then some of the regenerative therapies we use are exosomes and mesenchymal derived and stem cells in certain situations, and even peptides in a more precise way. So in terms of the framework again, we focus initially on the data acquisition and the initial phase on the front end, creating a digital representation of the person, and then kind of creating the intervention engine based upon, what their condition is or a pathway that we're going to take them down. And then we look at outcomes on a continuous basis, whilst also the intelligence is learning. So we look at trends, protocol refinement, biological age scoring, readiness metrics, and some other important metrics as well. So we look at you can envision that this is a continuous longitudinal feedback loop. So we call it adaptive health intelligence because it measures, excuse me, it measures the model, it reassesses, and then we intervene. And this is continuously ongoing. And there's also continuous engagement with the patient, or the consumer that we're dealing with, because they have to be proactive even in their own care. So over time, the result is it becomes more precise, more effective, and more personalized with every cycle. And some of the advanced technologies we use, generally we try to stay away from things that are non-toxic, that are natural and regenerative in nature, like hyperbaric oxygen therapy, neurofeedback, precision peptides, and supplementation. And I say precision because a lot of people are not one size fits all. And as you guys all know, it's one of the biggest problems we have in our medicine, especially in Western medicine. It is a one size fits all approach for the most part in terms of even prescribing, pharmaceuticals. And of course, that's associated with a significant amount of adverse, side effects, which in some cases can be, deadly. And then there's continuous monitoring. And obviously the wearables are getting better. They're not perfect yet because some of the algorithms are still somewhat flawed, but they're definitely getting better. One of the doctors mentioned a case, I couldn't hear it completely thoroughly, but a case where one of the patients had an alert from the Oura Ring, and then which was I guess very sensitive, and then a few weeks later or a couple of months later passed away, unfortunately. And I've seen that happen with these wearables where they do track certain trends, but the engagement is not necessarily there until the point where it's more of a an alert system or like a sentinel. And I had something that happened to a friend of mine, his husband last year, where they were super fit and healthy and wore an Oura Ring, and he had it on at 2 a.m, had a massive heart attack and died. So there's still, some issues with these devices. So the monitoring has to get more precise. It has to be continuous and looped. And the patients, consumers have to also be engaged so we can intervene before these, bad things happen. So I talked a little bit about this early on in terms of things that we test in certain biomarkers, comprehensive blood panels, hormonal profiles, metabolic indicators. We look at a full genomic profile, epigenetic analysis, metabolic assessments, neurocognitive testing, the brain mapping, and other forms of performance testing. And then these are just examples of some of the pathways. And it's really mainly based upon these core groups that we're dealing with now. You see on one of the slides that will come up here soon in terms of elite warfighters and professional athletes. But we have these integrated pathways because of the things they specifically deal with because of their profession, from PTSD to traumatic brain injury, a lot of musculoskeletal injuries, as you can imagine, as well as, some things they, deal with in particular, being warfighters, like mortar blast injuries and like chronic autonomic dysregulation, which leads them to kind of get in this continuous cycle of sympathetic overload and fight or flight. So we run them through these care pathways to mitigate this. This also translates over to even the general population because people are dealing with a lot of the same things. So this model in particular, we designed for elite warfighters, first responders, elite athletes, high-performing individuals that are under extensive amounts of stress. And it translates. It ultimately will translate to the general, population because it's focused on precision and personalization. One of the other main reasons why we, take care of these guys, and me personally anyway, they're close to me. I was a military school kid and I've been friends with these guys forever, especially the special operators. And I played high-level sports and taking care of a lot of elite athletes. But these are folks that kind of operate at the highest levels in terms of performance and under stressful conditions. So they're some of the best populations to test these protocols in and refine these models that ultimately can translate over to the broader population. The other thing that's also really relevant about our ability to use these advanced technology platforms and health intelligence platforms that we're developing and advancing right now is it allows us to be better connected, not just in clinic or, through telehealth platforms, but throughout the global diaspora. One of the other doctors was talking earlier about that using digital technology, and I was glad to hear that. And these things are advancing rapidly. The large language models are getting better, but I would venture to go even further is that when you can develop a health intelligence platform that is continuous and is constantly learning and adapting, it becomes more agentic in nature. And then this also can be connected to a broader ecosystem. So we can actually help people, all over the world, no matter where they are, as long as they're able to connect, through a cell phone, which most people have. So we think that the vision, for the future in terms of medicine is not just constantly prescribing or what's going to be a better, pill, but systems that continuously and precisely and holistically, understand you. So we are looking forward to continuing to advance this. We're looking forward to where medicine is headed, and we are super excited about that. We're heavily involved with some of these advancements and working with some incredible partners in different parts of the world that are brilliant engineers and, healthcare experts. And we welcome, the opportunity to collaborate with colleagues, all of you there and wherever you are. So, we're always open to that. So, having said that, again, sorry, I couldn't be there in person. I was really looking forward to getting back to St. Lucia, but unfortunately my schedule did not allow it. So, but Micheline, thank you very much for the opportunity to participate. Yeah, you're on mute, Micheline.
Am I on mute? You can hear me. I
Yeah,
just want to say thank you. I know you have such a busy schedule, and I think that you have such a busy schedule, and I'm really grateful. I was looking forward to you being here in St. Lucia, but I do understand. By the way, this is such a great vision. Is there opportunity for silent investors?
Oh yeah, I mean, you know how I am. I'm trying to, like I told you before, and we're actually on a side note, we're working on that. The other program I promised you we would work on in terms of building that repository and database. So we always look to collaborate, and the more we can collaborate with our brothers and sisters throughout the diaspora, the better. So we don't operate in silos. That's another big problem with, just the state of our health in general. You have a lot of brilliant people, but people don't communicate well. So this technology that we have now, finally, I mean, I wanted to do this 20 years ago. People thought I was crazy. And now the technology is finally advanced to where we can actually do these things. We can create digital representations of people. I mean, digital avatars and have them be almost like living, well, obviously not totally living, but we could do some pretty awesome things. So we are open to collaborate with our colleagues anywhere and everywhere that are trying to positively impact the lives of many.
Yeah, but something before Professor Oscar Ocho say anything, I think between yourself, Dr. John Boladeco, Dr. Clifford Thomas, we have a young gentleman here, Mr. Felix. I mean, all of you are in what you would call, someone talk about the pulse beat. And I think all of you coming together could be a real revolutionized system that we all from the diaspora can really clap and say yes. And I think collaboration, definitely integration and investment is a way forward. I'm really proud of you all. And I just want to say, I'm so glad to see you all at the forefront as people of diaspora in the vision of health and tech. Give them a round of applause, please. Go ahead.
Dr. Lomax, this is Dr. Ocho here.
thank you so much. We're going to have the pride and joy of St. Lucia. Let me just get her on track. In the meantime, could we have an icebreaker? Could we have a few people in the audience to tell us how they feel so far? I know it's been a long day, but we really wanted to share with you and let you know what's happening. Could we get a bit of video caption on that, please, whilst I pull up Jasmine's
Yes, that mic's away. You have none on that side? Where should we go then?
We take the job as person, but we very thought.
You're all very appreciative to be here and getting all this information. I implore you to take out your phones, open up your app store, and download the TikTok app. Whatever gripes you may have with the internet, I just want you to not even understand, I want you to understand the experiences that you've had and the years that you've collected to be able to come and share the stage and talk about these things. We've lost, the generations after you have lost the drive, the independence, the creativity to walk in the shoes that you have walked today. And I'm so grateful that Dr. Alexander allowed me to join her on this opportunity today. And I can't help but think, imagine if everyone who brought just one person of my age group, and we had the opportunity at dinner to be able to sit together and talk about the things that we have now gained from you. And you have now bridged the gap for the next generation to be able to create opportunities like this. So I don't want this experience to, for lack of better terms, end with your generation here. I don't want the responsibility to be on my shoulders to carry the weight of the legacy that you all have in your individual stories. I asked you, if some of you have children, make your children do it. Make them take the videos for you, make them record the content for you. If you are teachers, have a student who really needs the extra credit, do the work for you, because we cannot continue to do the work if we don't have the help, if we don't have the know-how, if we don't have the leadership. So I implore you and I encourage you, perhaps next year, invite a neophyte to come in and share this experience, because I'm overwhelmed with the opportunity to be able to hear all of your stories and share some of the heartfelt conversations that you've had with me. And I almost feel like an only child, like I get to experience the whole community. So really, I want you to overly understand, I'm very grateful to be here. I really appreciate it. Thank you. Download TikTok. Share your story with the people of the next generation.
Thank you, we have room for no more. You were so correct and comprehensive. Yes.
Thank you. Thank you for your patience, everybody. Yasmin Leons have been adopted as Yaz in the UK. The UK people call it Jazz. Well, no, really a pleasure to be here and for this terrible global influence in solutions. To my team, everybody's come down, all of you have been supporting here online and being part of the discussion to strengthen, promote our youth and celebrate our youth. So in terms of my title, I'm a consultant obstetrician, so I really specialize in pregnancy and childbirth. And I do spend most of my time supporting the National Health Service, looking at maternity and policies. So I look at the inequalities, choice personalized care, really supporting them and trying to improve outcomes for women, and especially for Black women in particular, as we know what the maternity statistics say around women, Black women, Black and brown women, through childbirth, and we're really working very hard to try to improve these statistics and thinking about care. But I thought we can't just talk about pregnancy care. We have to think around women's health. All the discussions we've had today, we're talking about social determinants of health, and we can't talk about pregnancy without talking about women's health in general, I believe. So when we start thinking about women's health, yeah, so essentially, this is about why women's health matters. Professor Rotini mentioned earlier that we all have moms, we've all come from mothers, some are not here today, including my mom. I mean, Joanne is here, my sister is here, and mom passed away years ago due to cancer.
I spoke to him already. He said
Having a mom is important.
play.
Women have pregnancies now in different ways. We've got in vitro fertilization, IVF, but still, babies have to be born. So women are the center and pinnacle of health. So we need to really look after our women. Nobody else could do that and bring life into this world. So big round of applause for all the women who are here and all of the mothers as well. Really important. So we need to think about some of the challenges and the successes in the Caribbean around women's health, and really thinking about what the opportunities are for change, for collaboration, and really bringing it back to our youth. What does it mean to our young women in particular around women's health? Next slide, please. So why women's health, and why is women's health important? Women are the backbone of families, of our cultures, our economies, our communities. We think about the whole approach in terms of the life spectrum. We think about our teenagers when they're back at the menstrual cycles, thinking about the reproductive age, and thinking about sexual health, very important contraceptive advice. And as you bring our women into adulthood, young women, thinking about optimizing health for pregnancy and childbearing age. We talked about the non-communicable diseases, so diabetes, high blood pressure, medical conditions that can occur, and really preparing for pregnancy. What about nutritional elements, folic acid, other things such as smoking, optimizing health, lifestyle, weight. Yes, weight gain, obesity is an epidemic, we know that. And we really need to be optimizing health for pregnancy. And after pregnancy, we think about postnatal care. How do we think about preparing? What have we learned from pregnancy and preparing and planning for future pregnancies? And as women grow and get older, thinking about preparing for menopause. So Dr. Tanya spoke earlier around menopause in particular. She didn't mention, but equally about functional health. The changes that we go through in the menopause around cortisol, hormones, so it's all interlinked. So it's very important to be talking about women's health. And also, women, we're expected to do everything. We need to be breadwinners, raising children, sometimes on our own, you know, and really thinking about doing multiple things. You have to be the breadwinner at times. Women have to be represented in terms of healthcare, or it could just be in terms of other opportunities, career opportunities. We want women to be engineers, to be pioneers. All of you are here today with different career paths, teachers, innovators, and we want women to be on the global stage. But we're competing with many different challenges, which is why women's health is again so very important, and we need to be thinking about our youth, our young girls. How do we prepare them from very young to navigate the path around having kids or not, but also navigating the different multiple opportunities, challenges, obstacles that they may face as we progress. Next slide, please. So what about maternity and health inequalities? Women deserve health care that sees them fully, not just in crisis, if you think about pregnancy in particular. In solution, birth rates is actually reducing. And we ask ourselves why? Why is it? Is it because women don't want to have kids? Is it because that they're getting older, focusing on the family, focusing on their own health? Is it that they're not in a fit state to keep them back on the pregnancy? They can't afford it. We talked about financial elements, about social determinants of health. Can we afford to have a child? But this is the reality that we face, certainly in solution. And maternity care needs to be safe. And we have to think about all the elements, pre-pregnancy, things like preconception counseling, thinking about contraception, if they're not going to get vaginal pregnancy, how do you obtain this information, and really thinking about a holistic pregnancy journey. And if women do get pregnant, what choices are available to them in terms of holistic care? Again, thinking about their mental health, thinking about their social health, the religious, the cultural elements, to really deliver safe, respectful maternity care. And also thinking about supporting reproductive goals that we talked about earlier. Next slide, please. So in terms of maternal mortality internationally, when we look at lots of reports from the World Health Organization about maternal mortality, some themes come through around what are some of the contributory factors to maternal mortality. And the first thing that comes up is about health system failures, poor quality of care, disrespect, mistreatment and abuse for women, thinking about staff, how staff are trained to look after women in pregnancy, the skill mix, staff shortages, what about medical supplies? Do we have these available? Social determinants, talked about already. Yeah, thinking about holistic approach. Harmful gender norms and inequalities as well. How do we prioritize women, girls, their rights to safe, high quality care? And other external factors in particular contributing to instability, such as climate change, humanitarian crises. But these are the realities of maternal mortality. Next slide, please. So what about the strengths of the Caribbean? We're thinking about our women, and what are some of the strengths we have in the Caribbean when we think about women's health? We have a strong community culture. We've got family support systems where it matters. Skilled healthcare professionals, some who may stay locally, but some who may actually go regionally. Sorry to say, some go abroad, in particular. But we think about resilience to crises. We think how we overcome COVID in particular, how we deal with COVID, and we're trying to recover from COVID. All of us in the UK, the US, and internationally, and think about how we all came together during COVID to optimize mental health, the general health, and well-being. Next slide, please. So other Caribbean successes we've noted. The Caribbean has very low maternal mortality. And if you think about St. Lucia, it's actually, I think it's around 40-something per 100,000 births. And that's come down significantly over the years. And the average maternal mortality, you can see, is 197 per 100,000 maternities. Okay, so St. Lucia is much better, doing very well, so that's something that needs to be celebrated. Other countries in the UK, it's probably around 12 per 100,000, so not as good as the UK. And the top countries are the Nordic countries, Norway, where they're doing very well, particularly. So we've still got some work to do, that's something to be celebrated. Universal antenatal care access is a big thing. So we're going to have free antenatal care, and that should be celebrated in Caribbean and also in St. Lucia. We've got highlights of skills with attendees, our midwives, always thinking about our workforce supporting pregnancy antenatal care. Another success is that maternity mother-to-child maternity transmission has reduced dramatically in the Caribbean, and particularly with Jamaica, Barbados, that's also something to be celebrated. And this is all regional collaboration with partners, Pan-American Health Agency, American countries, working together to make these significant changes. And as we said, in solution, but we do some coverage in particular. Examples, and you've got to introduce yourself. Welcome. To celebration and success. Well, what about some of the challenges and opportunities we can think about? We talked about maternal inequalities, rising non-communicable diseases. We've talked a bit about diabetes, high blood pressure, optimizing our health, cancers. We talked as well. Cervical cancer and breast cancer are a reality. But it's good to say that again, the solution government have embraced screening, cervical cervical cancer with human papillomavirus screening, which is what causes cervical cancer, and it's up to probably 90% at the moment, but that's something to be celebrated. And breast cancer screening, again, is free in terms of mammography testing and really embracing screening for breast cancer. But there's still strides to be made in that respect. What about mental health and gender-based violence? Mental health is so important, and I don't think we've given it the time today to really discuss it properly. But mental health and well-being very important in terms of pre-pregnancy, also for teenage girls, if you think about that. We have this whole body image, we talk about TikTok, and it's out there where, you know, girls compare themselves to models out there, everybody's having BBLs and, you know, fake things that I'm not here to criticize, but, you know, where we grew up, not thinking about these things, but this is the society we live in now where young girls, you know, are more confident in their body image and sometimes experiences their mental health to the point where they want to commit suicide or going to severe depression. So how do we support our young girls to pride in themselves and to maintain mental health and well-being? Violence, again, a reality in St. Lucia. You know, you have an argument, woman is shot. That shouldn't be happening today. Should not be happening today. And there's lots more we need to be doing. And the government is committed to trying to address violence against women. Our women are not alive. They can't contribute to society and can't contribute to increasing population. They can't become innovators. They can't become the leaders of the future and tomorrow. So very important about that. Workforce challenges and migration. What about the skill mix? A lot of our midwives might be going elsewhere, to the UK, going abroad, and the different islands have different curriculums around how to support pregnancies in particular. So how do we make sure our curriculums and the training opportunities are there to look after women having pregnancy and antenatal in terms of having that consistency of care, but also managing personalized, centralized care as well, where we have that holistic approach to care for our women. Climate change is a big thing. Talked a bit about that. We've got hurricanes, we've got floods, we've got lots of things. The changing temperatures is hot. Women accessing care, we have road blockages, and really it's a big thing for us in St. Lucia in the Caribbean. But again, the government is committed to looking at the infrastructure and dealing with climate change as well. Next slide, please. So what does this mean for our youth and our young women in terms of women's health? It's really about having culturally relevant life messaging. How do we meet our needs of our young people? How do they access information through social media in particular? As Joanna mentioned earlier, as somebody mentioned TikTok, we download TikTok. We have to think creatively and individually around how we educate our youth. Libraries, books, resources, and making sure we are part of the discussions around messaging. So very important. And optimizing health from an early age, as we mentioned, thinking about the social determinants of health, also the non-communicable diseases, lifestyle, to prepare them for adulthood, pregnancy, for reproductive health, also to maintain long, healthier lives. Digital elements, thinking about how they support themselves, mental health apps, pregnancy apps are out there in the UK. Women are relying on these things. How do we bring that to the Caribbean? You know, to make sure we can link and communicate with each other in terms of coordinating care through digital elements and digital means, and working collaboratively and holistically around the multidisciplinary function of holistic care, culturally, religion, and also medical illnesses as well. We want to prevent these, not to treat them. The prevention is the key. And ensuring that our girls and like our young women can thrive, that their voices are central to policy change, and that we can prepare them to be the innovators that we know our women are there. All of us are examples of, because we can't ignore the importance of our young women and value in today's society. Next slide, please, last. So the future of women's health, success, we have unfinished business. We've produced brilliant women, but our women are innovators, caregivers, leaders, entrepreneurs, and change makers. But we need to be shaping these conversations, not just in boardrooms, but really by having our women, our youth, our young women involved in conversations and being the center of change and policy. Because when our women are healthy, empowered, and heard, societies will benefit. Thank you very much.
Whoa! Wow! Oh my gosh, that come on, young woman. Come on.
You know what's happening. Can you feel the change? Can you feel the change? It's real, can you feel the change? It's like an avalanche, isn't it? We are coming out. We've gotten in from the, come on. From the cold. Come on, sing it. You know the song? Let's do it. Coming in, coming in from the cold. We gotta say different now. We women are coming in, coming in from the cold. I'm not really hearing you guys. Come on, sing it with me. We women are coming in, coming in from the cold. Let me see you march. Come on, women, come on. We women are coming in from the cold. Tell me what I do. We women are taking over. We're taking over from the cold. We women are coming in from the cold. Yes. Wow. Thank you, the jewel of St. Lucia. Yeah, give a round of applause again, please. I know I could see Professor Ricky starting to perspire. And John was watching me with his little, eyes and yes. Chemical pathologist is coming. I can see the name Marilyn something. You understand? Okay. Tricia is gonna introduce you. You know you're amazing. You're St. Lucian, although you're born in England, you're St. Lucian, aren't you? You're so amazing.
Speaker, you're close to the speaker.
Let Tricia introduce you and you do your thing.
Very close to the speaker.
You're gonna hear from a lay person. Go ahead. Go to Tricia.
You hear me? Okay. I'd like to introduce you to Sarah. Sarah.
You have any more audio?
Is, as Margaret said,
You have any more audio coming in?
And this
From here?
here is of your mom. And this lady actually will go down in the history books in the UK in terms of the transplant. Over a period of 30 years, okay, she received 2 living donor transplants. Yeah, think about it, 30 years ago, where was our medicine in terms of advances and so on the transplant compared to today? And 2, the donations from this, yeah, she got those added years to her life. And Sarah is what we would call a patient advocate voice, and she shares her story. And what my queen has just whispered in my ears is that going forward, Sarah and I will be doing work for the Caribbean region in terms of raising kidney health awareness. And every July, for the past 4 years, this will be 5 years, I will walk, kidney walk in memory of my mom, who also had kidney failure.
and I go out to raise money for the charity hospital if she was from Cardiff. So I'll be bodying up with Sarah to help raise more awareness across the region. And now I will hand the mic to Sarah so she can just give you a brief insight into what her journey as a donor, living donor, is like. Okay, so I'll hand it to you now.
Good afternoon, everybody. Thank you very much for having me here today. This is a very personal story. Obviously, it's personal because it's my mum, but it's also personal because there's 3 members of my family. My mum was age 44 when they first diagnosed her with kidney failure. My mum was overweight. My mum suffered with high blood pressure, but it was never detected by our GP. My dad's friend, Uncle Simon, he inspired my dad to take my mum to go see a private doctor in Harley Street. And it was there that it was discovered that my mum only had 5% kidney function. 5% kidney function. We were devastated as a family. My parents considered selling our family home so that they could pay for this operation. Thankfully, the doctor referred my mum to St. Thomas's Hospital. In 1989, my sister donated a kidney to my mum. It lasted 16 years. However, in 2003, the kidney started failing, and I became the donor in 2004. I celebrate the 4th of March like it's a birthday, and I celebrated that with my mum for the last 21 years. Unfortunately, my mum passed away last year. My mum came over here to St. Lucia. This is their home. My parents are both St. Lucia, have an appointment now. What I want to emphasise to you is whilst myself and my sister were kidney donors, we see it as a gift of life. I'm here to represent Black living kidney donors. It's something precious that you can do. We're born with 2 kidneys, and you can live with 1. You can live a very healthy life. Okay? That's the first thing that I really want to emphasise. But the most important thing that I want to speak about is the fact that kidney operations are very common amongst Europeans, but they're not within the Black community. There are many stigmas attached, and many people don't want to put themselves forward for whatever reason. But I stand as a living soul and to tell you that you can do it, and it's not harmed, and you can still live a healthy life. That's very important. So, my mum had 37 years. My mum watched me graduate. She saw her grandchildren born, her great-grandchildren born. She came to St. Lucia every 6 months with my dad. They built their dream house in Bonterre. They lived life. My mum was not on dialysis. At no stage did my mum go on dialysis. She was fortunate. Whilst people laughed at her and said, "You've got 9 children, got a big family, did you not do construction?" Her children helped her. They gave her a second chance. And what I'm trying to emphasise here today is if you have the opportunity and you can be a donor, remember you are giving somebody another opportunity. They can have better outcomes. You don't get those same outcomes when you're on dialysis. You're on dialysis 3 times a week. It's a lot. Watching my mum die of kidney failure was heartbreaking. But the most important thing is, at 21 good years with my mum, really, it was actually 37. So I just want to say thank you for inviting me today. Thank you to all the living kidney donors, and thank you to all the recipients. I know it's a tough job. Keep going, keep being strong. Let's keep raising awareness, especially in the West Indies. And as you just said, Jazz, let's pick up the mums. Thank you.
Wow. Oh, Rotimi, take that. I think you need to say something. Jasmine, just go back there. Yeah.
It's not easy when you see a family member who is really chronically ill with an illness that should lead to death. And when you are told that the only way out is for someone to donate a kidney so that it saves lives. And even donating a kidney or surgery, and yes, it is relatively safe, but every surgery has potential complications. What you have done is heroic. Yes, she was your mom, but you could have chosen.
After George is Stephen. Yeah.
Talking about parents, family, the nation.
Instead of
It's
kid
important.
myself.
One of the things I said is you look after your hands, like the engine oil,
I really have
so
to.
the engine doesn't knock.
So it's
But when it knocks,
Gilbert and Stephen.
you can't save the car engine.
He's sitting there with us too.
When it's about human body, we have to rely on human buildings. And I think that which is the constant thing we have, is that as a Black community, we should donate blood. We should go on the donor register. Very few of us are not on the donor register. And I have my reasons. I think it's this opt-in, opt-out. I want it to be voluntary rather than the government coercing me to be on the register. And I think we've also got to take away that myth of, oh, they will turn on the ventilator so that they can harvest your organs and stuff like that. But I want to thank you and your sister for giving Mom 2 leases of life. Like you said, seeing the grandchildren grow and stuff like that, it's amazing. So thank you so much. Whatever support you need, just let us know. And if she didn't absolutely, if she didn't tell you she don't let go one kid, would you know? Oh, yeah. So it doesn't change your personality, it doesn't do anything. But at least to save another life. So thank you so much. God bless you.
At this point, we'd like to introduce who is the governance director at one of the biggest NHS trusts. Gilbert, can you hear me?
I can indeed. Can you hear me?
Yeah, and do you have access?
I do. Is my
I can handle your stuff from here. If you
yeah,
just
okay, let's do that then. Yep.
Okay. Okay, Gilbert, tell us all about you.
Okay, well, first of all, it's a real privilege to be an honor to be able to present this afternoon on the subject of governance. But before I talk about governance, I just want to say a couple of things. First of all, I'm firstborn generation from St. Lucia in London. My parents are from Dennery in St. Lucia. And the executive sponsor for Global Health. I'm wearing a completely different hat from what I'm doing today, is that being the executive sponsor of Global Health, we have been working with the St. Lucian health sector in collaboration, building capacity on health. And I'm proud to announce that we're currently drafting a memorandum of understanding with the St. Lucian health sector. And hopefully that will be completed by the end of June. So my presentation today is going to be on governance. So if my slides can go up, are they okay? Up.
We're having a bit of problems here. Just a second. Could you put yours up, Chuck Gilbert? We're having some problems.
Okay. Let me see if I can share my screen, if that would be better.
Has he got permission to share?
Yeah, for some reason it's not working on my end. Let me try again. Hold on. I don't think it's working my end for some reason.
Okay, can you just tell me next? I will bring up that thing. Is that all right?
Yeah, do that. Yeah.
Sorry, guys. In the meantime, you can speak, Gilbert. We will be looking through that. Yeah.
You want me to? Can I just carry on speaking? Okay, I'm just going to carry on speaking about on my subject, governance. Okay, I'm just going to carry on. Apologies, folks, if you can't see my presentation. There's a lot of echo, so I hope okay. Right, I can't see. Okay, fine. Thank you. So I'm going to talk about governance and the importance of values in governance. Next slide. Okay, so when we think about the word governance, when we go back to the origins of the word governance, it comes from a Greek word, and the Greek word being kaibenon. And what that word really means is the ability to steer a course. And that's where the word governance comes from. And in essence, today in society, that word governance has been expanded in the way that we can control and direct society. And we know in terms of business and any organization, governance is a very important matter. Next slide. So governance has evolved from this word of steering a ship to steering organizations. It combines deep philosophical ideas concerning justice, power, and accountability. Governance is also key in the way that organizations are directed, and more importantly, how they're controlled from a state point of view. What's really important about governance are the following words. The words of accountability, transparency, fairness, and responsiveness are key elements of governance. Traditionally, governance is focused on rules and compliance and risk management. But what I want to talk about today is something beyond that, something beyond this mere compliance. Next slide.
The limitations of traditional governance.
Okay, so in today's society, when we think about climate change, AI, biosecurity, geopolitical issues, there are limitations to how governance can be applied, and in some areas, they don't work as well as they ought to. So we need to think about other ways in which organizations can be governed in a way to achieve their objectives, more importantly, in terms of society as well. The governance in terms of being bureaucratic and being rigid is okay, but really doesn't fit the purpose of today's complex world that we find ourselves in.
We don't know why that is happening.
Yes.
Meeting here.
Gilbert, can you hear me? Can you hear me at all?
I can, yes.
Okay, there is a sort of a noise that keeps coming back. We're not sure why. Okay.
Okay.
So I will continue. It's now slowed down a bit. I don't know why.
Okay.
So can you speak? So let me hear you.
Yeah. So I will speak and carry on with the presentation.
I'm not hearing you. Are you on mute?
No. I can hear you quite clearly.
The audio comes through on that side. Yes, please. Can you bear with us, please? We haven't had someone who's digital to look at this.
No worries. That's fine.
And all those who are online as well. Dr. Chavler, thank you for being here. We're having some real issues.
Hi, can you hear us?
Can you
I
hear
can.
us now?
I can very clearly.
Can you hear us?
Yes, so he can.
I can.
So, hold up. Volume. Where's the volume on this laptop? Hello?
Hello, I can hear you.
Okay, can you hear us now?
Yes.
Okay, and there's no echo.
Okay.
So you keep this one has to stick.
Can I ask you to just go through it with him, please? Okay, can you start from your second slide, please? And I apologize to you as a senior director in the NHS. This is beyond my thing. I have to say, Royalton is paid by the St. Lucian government to have an AV here, and I didn't know when he left. So my apologies to everyone around the world.
So
go ahead.
To go through this now.
Yeah, so we are on the slide where there's a lovely captain in the sea.
Okay, right. Okay, so I hope everyone can hear me. So as I mentioned at the very beginning, that the word governance stems from a Greek word, which is about steering a course. Organizations need to steer, and therefore governance is actually expanded in its concept to apply not only in terms of society, but also in terms of the way that organizations function. So I'm going to go on to a few slides. I'm recognizing that we're behind. So what I suggest we do is that we'll skip a few slides and go on to the slides that's titled Introducing Empowering Values. Okay, fine. Thank you. So, as I mentioned, traditional ways of governance in today's modern complex world isn't quite doing it. We've seen many organizations, for whatever reason, have not been able to uphold civility, doing the right things, and ensuring they're being compliant with the rules and regulations that has been set by governments and also by laws of a country. Where we need to move to when we speak about governance is something far more greater than purely being compliant with regulations. To ensure that individuals and organizations do the right thing, make the right decisions with the right behavior, something else is needed. And what is needed is going back to tradition. And what I mean by that is going back to values. If people apply their values in the way they make decisions, in the way they behave, and in things that they do, it's far likely they'll do the right thing, make the right decisions for the benefit not only of their organizations, but also to society as a whole. And so when people are value driven, it leads to being inspired, they're motivated to do the right thing, it leads to improvements in integrity, accountability, they're courageous for speaking up because they're value driven, they're respectful, they're transparent, they collaborate, and they're likely to be more inclusive. And if folks were to hold values in the way they conduct themselves and in the way they do business, then they will make the right decisions. When we think about the traditional way of doing governance in terms of just being compliance orientated, that's because we're being watched and if people are compliant. When people are not being watched, they will do what they want. But if individuals and organizations are valued driven, they will always do what is right. And that's where we need to move governance back to tradition, back to values that can stabilize organizations in their decision making and in their behaviors. The next slide, which I hope is empowering values and governance. So the whole concept in which we're trying to move to, particularly in England, in terms of our culture of organizations, is about creating trust, is about enhancing accountability, is about driving ethical decision-making, and fostering engagement and encouraging innovation, all underpinned by that word value. A small word, but a mighty word in the impact and the power it contains. So, in the organisation that I'm working at currently, we are under heavy scrutiny, the most scrutinised NHS organisation in the whole of England. And I've recently drafted a document called Public Accountability, based on values. And it's for me and others in our organisation is to change the culture of the organisation by working with the staff and with the board as a whole, so that we move to a more value-driven way of running the organisation, so that people feel compelled from their hearts to do what is right, and not just do what is right because someone is watching them. And so in looking at governance and in reimagining governance, we want to go back to tradition. We want to go back to values and bring them to the fore and try to enhance the way that organizations function. And so that's what I'm driving at the moment in terms of the organization that I'm currently working for. That's what we try to drive through the NHS as a whole in terms of as an organization. And in fact, any organization that serves the public, as well as endeavoring to be compliant with regulations and laws, must also endeavor to build values within the culture of the organization, so that we do the right things for the right reasons, make the right decisions, and more importantly, conduct ourselves in the appropriate way. So I'm going to stop there. I really do apologize with the technology, but hopefully you'd have got a sense of the discussion today, which is about values and how we can use values as underpinning the way that we do governance in our complex and difficult society that we find ourselves in today. Thank you very much. And once again, I do apologize, but hopefully the presentation will be circulated to all so you can get the essence of what I've been discussing this evening. Thank you.
Thank you, Gilbert. I can tell you that, network issues is not St. Lucia issue at all. We have it you know that. We have it everywhere in the world. So it's not really the network, but IT, digital people in the room, you know what it is like. So we can't fuss about it. We have to be considerate, and it's the message. I tell you what I've picked up from it, because I'm a governance queen myself. And I saw that, and I'm going to call it a C-feed. That is what I'm going to call it, a C-feed, creating feed, creating fostering, encouraging, ethical, enhancing. That's what I'm going to call it, and driving. It's got to be my C-feed. Brilliant, brilliant presentation. This is a gentleman who's part of the Governance Institute. He is called upon by Lord Mayors, by so many, the City of London, everywhere, to speak on corporate governance. We are so proud of you being from the Caribbean, and we call it all the great halls of London, of the United Kingdom and beyond, even far abroad, to talk about the importance of corporate governance. You are our hero. God bless you. Thank you. Thank you, Shotland. Okay, I will let you know that we have one last speaker from St. Lucia again. The other speakers, we put them on tomorrow because they need to do mentoring. I just want to thank you all for staying back to work this through the day with me, especially me with my lovely little slipper. But I just want to say thank you all. Now, this gentleman, I don't know much about Steve. Stephen, will you come forward, my darling? Can we give him a round of applause, please? Okay. What I can say is that we talk about digital, and we talk about electronic health records, and we talk about all of that good stuff. Being part of the NHS digital world, you know that. But you know what's beautiful? When we are not buying what is being offered to us as created. This is created by Solutia for Solutia. Give them a round of applause, please. And I hope the Ministry of Health and all the other private organizations across the Caribbean and everywhere recognize and understand the landscape of the region. And based upon that, you see Ola, you see who is from Nigeria, Professor Lutifi Will, she's smiling. But you've done a great job in bringing it forward for our attention. Give her a round of applause, please. So, can you tell us about the medial health before we put on your presentation? And I'm so proud of you, young man. Oh no, I'm not young man. You know, I just wanted to put my age there. So yeah.
I think I'm joking off. Hi everybody, I am Stephen Felix, on here and really experienced a lot of healthcare. I mean, not a lot, because I've never really sick, but like experienced healthcare and also like in the US when I went to college. And few things happen. So I have this place records there. And I don't know if any of you know, but over 90% of medical records in the Caribbean and Latin are either on paper or not digitally accessible. Meaning, some hospitals have a system that is all silent within that hospital. So then it only becomes valuable if the patient goes in, right? Another thing is, motivated story for me, I lived in New York and I was physically assaulted. So I needed to have vaccine information. So you can't tell, great savings. But my records were digital from one hospital. I was transferred to another one and they said to me, hey, we cannot use those records, meaning MRIs, labs, whatever. They couldn't use it. They had to redo everything. That's cost, that's time. I was feeling a lot of pain all over one payless, but I was feeling it. And the psychological and mental burden of knowing, hey, I just spent so many hours and made so many trips to a specific hospital only to transfer those records, and it could not be used. This is when media health was born. And that is why I'm so driven, motivated to do this and transform the entire group.
Take the stage. Thank you. Wait a minute. George, can you hang up, please? Thank you. And not hang up, but you know what? Just close up. Yeah. Let's just get this on. Hold a second.
So while we wait, what I'll be talking about is the Caribbean being many individual nations, but lots of the governing bodies, the health bodies, the research, etc. They're all regional, right? You have CARPHA, you have the Pan American Health Organization. There's WHO projects that happen all the time and are funded. And a big issue that comes up is data, right? And how do we access data? That's not only accurate, but that's also timely. Look at COVID, right? That's still the only pandemic I know about to have lived through, right? And lots of times it was so difficult just to get to know if there was this person vaccinated. How valuable are those vaccination cards, those paper cards that were passed along, right? How vaccination and those, etc. How valuable are those, etc. So that's one of the things we'll be addressing is how do we connect the Caribbean digitally and still respecting all the governance we just did, right? Respecting all of that, data laws, privacy information. It's not only regionally, but within country within a specific medical center as well. And again, we have lots of other things, medical tourism sector that's booming here. How can we ensure and how can we have patients know that the data is actually safe and it's being accessed by the folks who need to access it at the time of the event? So
Just bear with me, having a little bit of bringing up your presentation. Okay, can you see that now? No, it's still not. This is the worst I've ever encountered. Is it up?
yes, it's up.
Woo! Okay, young man, let's do this before it goes.
No,
Okay.
what we're going to talk about is just connected care, right? And why the Caribbean needs a health information exchange. Right? We're going to talk about what's in HIE, why we need one, and how it connects to the work of institutions like PAHO and the IDB that they're already reading in those ways. That's okay. So, what is an HIE, right? It's infrastructure that lets a patient's record follow the patient. The patient is moving from one center to the other. We need the history. We have plenty of physicians as well. And so a lot of times with history that's not even collected by us, right? Because that patient may have gone to so many other physicians before coming to you, right? The way this looks visually is that the exchange sits in the middle and we connect clinics, hospitals, labs, pharmacies, right? On top of that, I just want to define some of the things. An EMR, a record, an HIS, that's the one platform that the entire facility will use. You have admin, records, billing, everything all in one. That's your HIS. The health information exchange, which is what we're going to speak on today, is the connective tissue between all of those digital systems. And think of it like a road, not roads. And a road takes you to places. Yes. So there are three ways information moves. I'm trying not to be technical here. One is directed. So you can push to a known provider, you have a referral, you have like a medical report, a medical summary, a discharge summary that you want to write to a specific physician. That's directed. There's query-based where that's at the point of care. You need this information, you're going to ask for it. Now, you might ask another doctor, but here you're asking the system for this information as well. And then there's consumer mediated, which are patient control. We need to have patient's involvement in the data, right? So the patient should always have a right to say, hey, here you can have this piece of data, or I choose not to share this, right? Underneath all of this, you need identity, right? You need a directory of services. So you need to know where those doctors sit, what services they offer, etc. You need lots of standards. So I'm gonna just name three because I really love those three, but SNOMED, ICD, etc. You need standards to exchange that information as well. And FHIR is the globally recognized way and data model to actually share information in terms of how to share it, but how do you actually define that information to be shared? Thanks. But the reality of the Caribbean, many small jurisdictions, there's constant movement and many or one fragmented record, right? So we're scattered by default, many different islands, many different medical facilities. People move, but the data doesn't. Think about all of the different ways that we've been empowered to move and work in other islands, right? You have a CARICOM, where people are allowed to move and work in different places. The OECS countries as well, and I simply can go work in an OECS country, but my data, my health records, things that are very critical to my survival and my well-being stay here in seclusion. Then you have governments, right? Many different ministries and countries, many different ones, right? There's no single authority that can mandate a regional system, right? And then fragmentation has a cost. So COVID is one of them, but there's so many other ways in terms of data being fragmented, the patient moves to get care in another country and doesn't have the adequate medical records. So now, I mean, you as a doctor, you have to do so much more because again, you really care about the safety and the outcome of that patient. Next. So with that and a solution like this, when records follow the patient, every part of the system gets stronger. First, you get continuity and increased safety. That's the patients. You get a full picture of that patient, right? Then you have real-time standardized data. Think about things moving on paper or Excel spreadsheets, etc. And someone still needs to go in the lab. I mean, you have AI now to do some of it, but somebody or something needs to go in there, right, to extract whatever data you need from it, right? And you might still miss certain things, right? In a system like this, efficiency and speed is a foundation, right? So we want to have less duplication, lower admin costs, etc. Right? And it also creates a base layer for analytics and AI. In the region, I think it was mentioned earlier, we don't have a data in the Caribbean to support the type of research we do. Right? We get excluded from not just clinical trials, but like lots of things like medications and testing and all of those things. We are excluded from because all of the medications that we import, right, there are no reporting or outcomes that are sent back to the manufacturers or the pharma companies, etc., to know, okay, is this really helping us? Given the temperature, the humidity, the level of salt in the air, so many things. Is it really helping us? And we're out of all of this. Then you have governance, which is sovereignty and trust. The data will stay or should stay under national control at all times. Right? That gives rights for audits, consents, all of that being at the national level, not a regional level. So not because all of the countries and the data is connected means that anybody should be able to access it or have control over it. The control stays within the country. Next. So when we look at certain things that were actually born in the Caribbean, there's the Information Systems File, right, IS4H. This is FAO/WHO's framework for digital health transformation in the Caribbean, and that was launched in Jamaica in 2016. There are 5 maturity levels, first starting from just being digital, all the way to being able to code and exchange data. Right, the first goal of it is data management and infrastructure. Right, ensuring that we have interoperable systems, standards, and open data. When we say open data, we don't mean anybody can access it. We mean that this data is open to those who have the right privileges to be able to access that data and who need it. Second thing, management of governance. So policy, leadership, and basically rules of living. Imagine a highway with roads, right? Third, knowledge management. Turning data into usable information across formats, right? If I take data from Central and I need to train it with it, can it actually be used? Similarly to what happened to me at Boston. Data left with me couldn't be used, we had to redo it. Which tries to make it very functional. Then we have number 4, which is the innovation and performance. So after we get all of this data across, right? How do we study that data? How do we innovate? What types of tools do we need to build to help our doctors in the region, right? Some of those tools that were in, like, I guess, quote-unquote, developed nations may not be applicable or may not be the best use of our time and efforts. Next. So that was IS4H, right? There's also PH4H, which is the Pan-American Highway for Digital Health Highway, right? This one speaks more about how information should be shared, right? So This one is rooted more in care that follows the person, right? So continuity of care. How do we ensure that any system we deploy in the region at this time, right, helps with continuity of care for patients? There's also cross-border tools, cross-border information sharing, right? Patient summaries, right? Vaccination certificates, and e-prescriptions. I just had a well, I was in Barbados last week, and one of my friends had a prescription for a drug that he could have only worked in Barbados at this specific strength, and could not help her with that because prescriptions are not, I think it's an issue, I'm not buying in Barbados.
He's the last.
So yeah, being able to do all of this and share data again, that's also increases access to care. Last but not least, it was able to connect. So they also host like connectathons, which are technical interoperability marathons that are hosted with governments and ministries and policymakers of each country. Next. So when we think about HIV, this is what it looks like. So we have each country building its own section of that, right? For those of you who do long road trips, it's almost like a rest stop, right? Where you stop, there are different rules, different stores, different things that are available to you as you navigate this country, right? So each country builds its own, but we have shared standards that are adopted across those different countries, from the facility level, so all the way down to the small single doctor private clinic, all the way up to the United National Health System. Right, so those shared standards, again, some examples, WHO7, ICD-9, portals will be very familiar with those. But again, this is what an HIE represents. That creates the regional highway for data share, right? It's not a country's effort, right? It's a country's section of it. Next. So what we're asking here is, we're not asking countries to stop doing whatever they would like to do. In terms of, I mean, this is the work that we in Personal Media Law, our systems have been built to be interoperable from the start, and to be that backbone infrastructure that the Caribbean needs for data sharing. So here's what we're standing on. Standards over centralization. So there's no central data store for the entire Caribbean. We're helping to adopt standards. By design, it's federated. So the data stays in country, and then the exchange will request that data for every request. It's national first, where each country builds its own section at its own pace and its own terms. And when they're ready, they connect to this time. Local priorities will always be, right? Standardization will always serve the local context first, right? Because again, when you standardize all the data, you're able to do like your surveillances, you're able to do so many important things by having data that's real time, up to date, and coded to international standards. And then the last thing here is that governance, as we mentioned again, like super important. The product in an HIE is governance, right? Not the implementation of any system, but the governance of that data that is within the system. And we want to do this via consent, robust access, and having audit trails every single time the data is touched or modified. Next. So there are multiple ways to do this, right, in terms of implementing HIEs. The first one is centralized, where you have one shared repository. That's not going to work for us, right? Because every record will have to be placed in a single database or a single data store, and then you lose the governance, you lose the control over them. There's federated, where data stays at the source. So all of the records stay in each country, right? And then the exchange locates that information and makes it available to whoever is asking for that information. Nothing is true. Then there's a central index and local data, where you have just pointers or locations where that data sits. And if I need data from Trinidad, then it's going to know, hey, this is the location I go to get data from Trinidad. Next. So again, federation is the recommendation here from us, where you have each of the nodes have the facilities, the EMRs, the labs, etc. And the regional exchange layer is what's going to be directing traffic in terms of who needs what information and where to route it. But in each country, we do need some shared services, right? So we need identity, right? So that's a master patient index for cross-referencing, for ensuring that the patient who went to, if I went to the hospital and then I went to the private clinic, then it's the same person. So we need that. We need a provider registry. We need to know where the providers are, which is a trusted directory for providers and facilities, right? And allow them to participate in the exchange. We need a record. So just pointers and knowing where to find this information, a shared language. Our system, we've implemented all of the different shared standards, and I just want to highlight that we've been invited to, well, have a meeting with the UHC in terms of how do we allow private and public to actually communicate and share the information. That's within institution. And what I would like from that is for a model like that to be replicated across. So the public sector has a system, has information already digital. How do we now connect private patients, etc., public, but still respecting that data privacy, data sovereignty, etc. Oh yeah, consents and policies. I think a consent registry would definitely, this is super important because now patients, I guess they don't consent, right? All the information is on paper. So how do we now ensure that we have the tracking of that, right? And ensuring that we know that it's a patient who actually signed this on paper, right? And then again, trust and security. So we just want to ensure that everything is verified, audited. So again, if there is ever like a medical legal case or patient is reversed in day, I want to know everyone who has access to my data that the exchange will be able to provide that level of clarity to the patient. Next. Almost done.
No, it's fine.
So, what happens when a clinician needs a record? Right? Clinician at the point of care will request that information to the exchange, right? The exchange is going to identify, cross-reference, find every location that this patient has been to, then go ahead, locate those records, and then authorize based on consent and policy. Then that query is put together and sent to each of the nodes where the records are located, and then an international patient summary is sent back to the clinician. Right? Not every single detail of the record, but an internationally recognized patient summary will be sent back to the clinician as needed. That contains lots of important things like recent campaigns, vitals, family history, etc. Next. So the standards that we're practicing at our company, again, FHIR standards. So modern APIs and resources for structured data exchange, right? There are IHE profiles. These are various profiles that can be used to share this information and do lookups across various nodes. The international patient summary, again, a shared minimal record that is approved to travel across borders. And then common clinical terminology and coding, which is like dystonia, ICD codes, etc., for things like diagnosis. These are really going to help trust. The trust framework, so identity assurance. Only known verified participants join the network mobilization. So that means there has to be a process in order to get different facilities and physicians, etc., to join this. Right, have certificates and encryption. So transport layers is everything, even at storage or when the data is being transferred is encrypted. We need lots of consent and data protection. Lots of the data protection acts in the countries are backdated. So some of them 2014, 2019 is the latest I've seen, but we do need to have those in place as well. And then lots of conformance testing, right? So all of those connected parts. We got a pilot, we got to do a whole bunch of that before we go ahead into the systems. Next. this can only happen in phases, right? So first we need to agree to the rules. Thankfully, we the PAHOs and the IDBs, etc., are now setting those rules in place, right? Then we need to have national notes. We're already doing this. So we're doing this in 4 countries. We have St. Lucia, Trinidad and Tobago, Dominica, and Antigua. And just this last week, we opened up to the rest of the Lower Eastern Caribbean. So we're going to be deploying roads in every single one of the OECS countries, and Barbados and Trinidad and Tobago. Once we're able to do, once we get that done, we now create those shared services. We have a services directory, it's called CareCare Connect. And on there, patients can go in and actually find their doctors and book an appointment online. Prior to us launching CareCare Connect, this wasn't really a thing in the Caribbean. So again, increasing access to care by doing that. So I'm looking for an ophthalmologist or cardiologist. There might be one right down the street, but my neighbor doesn't know, and my neighbor doesn't tell me. I go on to CareCare Connect, I find I'm looking for an ophthalmologist, and I know exactly where they are, and schedule my appointment with them based on availability. And then the next phase we want to do with this is some cross-border pilots. So right now we're at this stage where we're proving this within country. And again, we're going to use that successful implementation as a stepping stone to go regional. And that's going to be powered by mobile technology. I've been to Trinidad multiple times. I've been registered with doctors already using our system in Trinidad and in St. Lucia. So with this, we're launching our mobile application soon, and that is going to help the patient connect those different needs, right? And then the last part of this, which is the fourth, which is like scale. So adding e-prescriptions, referrals, labs, different things that need to move across the HIE. Next. So again, first use cases, the International Patient Summary, vaccination certificates. We do have an immunization registry. We haven't formally launched it yet, but we do have that. And again, that's going to allow us to be able to share those within the region. It's already a priority for the Pan-American Highway for Digital Health. Then we're going to try on prescriptions. Again, lots of our countries in the region, the prescriptions are legally accepted. We want to be the ones to bring that, right? So that a prescription can be sent electronically and validated, and again, have the patient be served that medication. That's what happens when you have a virtual visit. You still need to collect that piece of paper from the doctor to take it to the pharmacy, right? We want to be the ones to drive that change in the region to have new prescriptions. Then we want to do labs and diagnostic results. There are always services that are not provided within the country, so the patient can travel and get the labs done and then come back, right? And then the results is follow. Next, referrals. That closes the entire coordination loop for them. Right, next. So, all right. So IS4 engineering calling for interoperability standards, right? We're providing this already. As a national section of the highway, we have live in production deployments. I mean, lots of people talk about this theoretically, how we're going to share data, etc. We're doing it, we're taking that risk. And again, we have a whole team that's again standing behind me, right? And we're getting it done, all right? Continuity of care, we do already have a unified patient identity and real-time data sharing across different settings. We're able to provide lots of public health analytics that we have some crazy numbers of there that we are not going to share because we're not allowed to. But again, once we start working with the Ministry of Health more and the folks who run the data governance, will be able to again make that information available to the folks who need it. Next. So this is St. Lucia in about 2 years, and this is only the private sector. So in about 2 years, we've already brought in about a quarter of the country to have digital health profiles.
Wow. Give him a round of applause.
And there are numbers that are on there, like a significant decline in no-show rates, because again, messaging, right? We do lots of messaging to patients, and it doesn't go through email because who in the world still checks emails every day, right? Unless it's for professional reasons. But again, like WhatsApp is a primary form of communication. So again, sending out those messages to WhatsApp and SMS, and we also have email as well, but WhatsApp is preferred by over 90% of people, right? 22,000 diagnoses being recorded, tracked, and coded. So they each they either have ICD, well, they all have ICD codes, right? Observations, 122,000, that includes vital signs and complaints, etc. All within the system, and that is simply shown. We do have data for Trinidad, we have data for Dominica and Antigua. And again, maybe by end of this month, everybody else. But again, this has just been like, this is work in progress. I do believe that as we start working with bigger entities like the governmental solution and the government's Inter-American Development Bank, that again, we're going to be one of the prime efforts for data in the region. Next. So again, in order to build this, there must be alignment on standards, right? We as a region need to build our own sections of this road, and then we connect, right? We're gonna build regional solidarity, sub-regional leadership, and again, all on shared infrastructure. So the same infrastructure that's running in St. Lucia is the same thing running in Trinidad. And we already have ways, like the system has been designed to connect all of those countries, but the policy and the laws and all of those things don't exist yet, so we can't. We want to drive that push that change. Next. So again, what does that now give us, right? When we have an exchange for 44 million, 45 million people in just Caribbean, right? We have real world evidence, and that can be used in research. So lots of the identified data at scale. So for clinical research, clinical trials, and lots of evidence that the region has never had. Right? For public health, that introduced more accurate and more timely live surveillances. So in outbreaks, right, immunization coverage across the countries and in turn across the Caribbean. And any trends that are being seen, right, we can set a little bit of thresholds, etc., to be able to identify any abnormalities or any trends that are happening. Again, that now provides evidence to plan, right? Where are we putting in the money? Right? Where there's like the Ministry of Health need to focus on, is it early education? Is it like advocacy movement, food, right? What do we need to do? That really helps policymakers to plan. Right? For efficiency, again, we're raising the quality bar, right? And increasing, well, we're helping to raise the quality bar and to increase the efficiency of our health system, right? So being able to flag, and people have decision support in the system as well. So being able to flag interactions, abnormal vitals, etc. We do provide lots of that. And again, a basis of AI. Another goal of us is again to, with consent, once those right things are in place, which models are we going to use in the region? Do we use one that's trained on data that's not from our region? Or do we need to build, in fact, we need to build our own models, right? We as data have the data to do it. And this is one of the ways that we can change the outcome of health and the outcome of the future in the Caribbean. Next. So yeah, this is us, and this is what we do. This is Media Law. And again, that vision for connectivity in the Caribbean and connectivity, not just for like the different medical centers, but to really put the patient at the center of care, right? This is what drives us, and this is why we exist.
Wow, you are amazing.
simply amazing.
Thank you.
I don't mean to be rude about ageism and all of that, but this is what we talk about innovation, isn't it? I could watch this presentation again. Give him a round of applause, please.
Thank you, everyone.
I have
Any questions?
Yeah.
This is highway, information highway. I noticed this information highway. The focus on the career. My question is, with connection with the internet and cloud and satellites, does it make any difference whether you started in the Caribbean or halfway across the globe? Can you say the Africa as easy as you
Absolutely. So, a good question. We've designed the system to work in low resource areas. Again, it comes to the type of data that's moving across, all of the different technologies that we've used. It's all about deploying one country at a time. So we can take this to many of the African nations if we have to. Right? But again, let's start home. Let's take care of our house first, right? Before we go ahead and say, let's jump ahead and go to town. But we can, right? And we can set up an entire country with this technology less than a week.
Any other questions? That's really great.
This was. I really wanted to commend you as a young man for your capacity to think outside of the box. And I can see this as a very effective model, bearing in mind its value to the medical tourism. My question would be, what are some of the ethical legal implications you can see as it relates to data sharing? Let's say for countries that may not wish to join, but whose citizens are willing to be part of the system, bearing in mind they may be accessing services in one country and they go back to their country to see their doctor.
That is an excellent question. So it's things that we have thought about in terms of the control of that information, right? We want to build this and deploy this in a way that, again, the patient has a say. So even if an entire country may be connected and the patient through the mobile device or through speaking to their physician, etc., that, hey, I do not want my data as part of this network, we have to respect it, right? Because again, for a long time, I'm not going to say patients didn't have a say, but there was not much advocacy for patients when it came to like healthcare because, I mean, they want to get better, so sometimes they just agree to things. But in this age, you have a lot more technology, a lot more knowledge, etc. And patients, they do have a say. If the doctor can do everything, and if the patient doesn't really want, they've been instructed to by the doctor, then they don't agree on the outcomes of the patient. So they will have a say, and that's why with mobile technology, the ability to track consents, including what I'm sharing, right? So backstory. Before building out this entire system, the first thing I did was a patient portal because I was just like, well, I lost records and I couldn't have this today. So I built a portal that allowed me to snap photos. I'm a software engineer, but I built a portal that allowed me to snap photos and share snap photos with providers, etc., and share specific parts of it. So if I wanted to share just my blood pressure readings and make it available to people who need it, I'll be able to share just my blood pressure readings. If I want to turn everything off, but share a single piece of data, I'm able to do it. So mobile app will have the same capabilities in because we'll be launching it, and even within the provider's portal as well, there's a level of control and access that we've put in place that if the physician and the patient decides, you know what, this diagnosis, we don't want to share with anybody, but the medical team, they can do that, and we respect that as a, not just as a company, but as a person. I respect people's privacy. A lot of those values go back into building the company. Can I answer your question?
Any other questions? As you can see, I can't pull up a file that I need to pull up here called LHD. So maybe if you can kindly give me a hand into pulling up this LHD, that would be great, because I want to talk about your company. Yeah, it's here. Okay. Go ahead, ask the question.
So, great stuff that you've been presenting here. Now, the challenge that when you started the presentation, you talked about quite a lot of stuff being paper-based. Paper-based. This is it. You also so I suppose there's going to be a lot of work in having to get that digitalized.
Trisha, is this connected to anything down there?
Because in order to hold it, keep it, I suppose you're finally going to keep it digital. So you actually are going to have to do quite a lot of transferring that paper data to digital.
So that is correct in terms of transferring and converting files and capabilities into digital. But that does not stop a medical facility or a hospital. I mean, we've done it, right? That does not stop them from going digital with our system. Right? There's a couple of things that can be used to help them. So again, there are projects that we provide services as well to like scan and upload into the system. But again, that's something they can do themselves. So if the single physician clinic wants their secretary to scan the documents and put them in, that's great. What we help do is we help with change management. So how do you decide which of the, as an aspect of change management, how do you decide which parts of those files that you actually move over and when? If you have a patient coming in next week, what's the digital before moving? We also have a scribe. Yeah, our scribe. And again, they can summarize this entire chart, right, through the scribe, and the system would build a coded version of a medical record. When I say coded, I mean putting all of the ICDs and doing the mapping and stuff, what the medical coder would do. We are doing that automatically for them. So there's no need for a coder to use it from the system.
Question. Most of your, well, I think all the information now is the private sector. What are your challenges with actually now getting into the public sector? Because that's probably the large part you really want to break to. What are the challenges of breaking into the public sector?
So I would say to that, in terms of getting into the public sector, I think it's just doing good work in the private sector. That's all, you know. So it's an issue again, when, I mean, with the universal healthcare, lots of doctors, especially from the private sector, were interviewed, right? Lots of those doctors are using our system, which they really like. And it was like, we're not moving to anything else, we're sticking to the media health system and the platform because of how easy it makes things for us, stay attentive, again, standards, excellence. And then now we've been officially invited to work with the government of Sufficient, right? We've done a pilot in Trinidad, we're now setting up the pilots in Barbados as well. So again, like just, I think getting connected with the right person. So again, partnering with the IND, right, Intermarine Development Bank, and the lab, etc., to the consultant work on different things. That's gonna get us into the door. But in the meantime, I always push the team, and we do have an excellent team and we just put excellence at the top. Let's do it well, and we'll be recognized for it. And we need to start making more noise with digital marketing.
Now, if you want to ask you what is called indirect marketing Lloyd question there, John. Very naughty, very naughty. Anyway, I just want to say thank you all. Would you be able to look at that? See if you could bring that up on the screen for me, please. That LHG. Wow.
This one?
Wow, wow, wow. Can you give us a round of applause, please? Yeah. I'm gonna go agile. You know, when you do agile, you go barefooted. I'm gonna go agile. True Caribbean woman. I'm gonna go agile. You can take pictures of my little painted toes. Come on, give me some round of applause. Naughty. Anyway, I just want to say, young man, you're amazing. I feel so proud. Tell your mom and your dad and your uncle and your grandma, I'm really proud of you. Wow. This is what we call innovation. Thinking outside the box. Impact. I do hope we have, on a serious note, good commercial lawyers. I'm going to talk to you now. Everything can be duplicated. Yeah. Everybody is your competitor. Everybody is running that race. Not everything that smile is a smile. I want you to be savvy. You may not want to learn from me, but I will tell you.
Tell me.
Intellectual property. You get the best lawyers in America and make sure you cover every corner of the globe. That's the first thing. Two, I don't care what government it have in the Caribbean, you make sure your commercial lawyers talk to them before you do. Yeah?
Yeah.
You need to bring in a good legal team, not that will take over your business, but a legal team that will make sure that your contract terms and conditions is the way that you want it. Make sure that you understand what is a memorandum of understanding and put a clause in that you can walk out anytime you want, once it's not going your way. Yeah. Make sure your team, I don't care how great they are, sign a disclaimer notice, a confidentiality notice, and a proprietary rights notice that belongs to you, Stephen Felix. If you need a list of documents that you need to make everybody sign, you let me know.
Oh, I will.
Okay.
I'll take you up on it.
When you go back to New York, go to Neil Weinrib. When I practiced law in New York, I worked for him. Neil Weinrib, you can look him up, N-E-I-L, Weinrib. And you tell him, Michael Holdemar sent you. He will love you. That he would love you. He's an old boy, but he's the best in the business. He'll make sure all the copyright, contracts, everything is as tight as it can ever be. I want you to be smart. Smarter than everybody else. And you see, John caught you out. Thank you, John. Because you see that question. That was a question I was waiting and seeing. Wow, John threw a ball there, and he was so happy to start talking. And what you should have said right there, that is a very good question. But that's a question that my marketing and commercial team is best to answer. As a CEO and the founder of this business, I only answer the strategic. I don't do the media. Give him a round of applause. So I want to hear you next time say, hey, I don't do the fishing. That's my marketing team, and they can't speak today. But I want to tell you strategically where I'm going. Bullseye! That's where you go. Okay, I'm looking out for you in 5 years' time for you to rule the Caribbean with what you do. Give him a round of applause, please. Right, tomorrow is about young people And some of you know who's leading on different tables. I don't need to ask you to join the table. There'll be 8 tables. Just find yourself on the table with the young people. You will have certificates of the Caribbean Global Institute. If you did the assessment with them and you think they can get a membership free for 1 year, you write their name on it, you take a picture, and you send it to Josephine or send it to Tricia. Tricia will send it to Josephine to put it on the database. Yeah? There is a group who will be looking at a clinical assessment for those who will be getting the pre-med scholarship certificates, those who will be getting the sepsis certificates, those who will be getting public health certificates, and then as you see George, Gilbert George there, those who will be doing corporate governance, etc. Yeah? So tomorrow is about giving and giving abundantly. And if you biblically know what that means, you're going to give abundantly, give unselfishly. I want to thank you all for being here. Let's go and eat some good solution. Have food. What you saying there, darling? We are all going to get together and get a picture up here. Can you come and tell me it's okay? So we are going to eat some St. Lucian hard food. I want to take this opportunity to do 5 things. I want to thank Sheila Williamson and Neil Williamson for being here. After a long to the House of Lords, Sheila just took over and ran and everything. And tomorrow I know we have work for you to do, and we are so proud of you. Neil, I know you brought a great jacket. I'm looking forward to you to join us to do with that. Thank you so much. I want to thank all those who came from abroad who are here with us. I know, sorry, Caribbean Global Awards don't have the money to pay for your flight, but I want to thank you. I want to thank you, Stephen, for the donation. I want to thank you, Joanne, for the donation, for the sponsorship. We'll be able to give a few of the awardees some money in their hand to help them to buy data. That's where that's going to go to. Buy the data they need to do the course. Yeah, because I know data is expensive and I want them to have a little bit of money in it. I will need to get some little more envelopes rather than just hand it to them like that, because it's not like if you look at it, you give them a check or something like that. That's the first thing. To the St. Lucian government, I want to thank you humbly for everything. Opening the doors, midnight calls, you know that, Jasmine, where MP Kenson Casnery joined us in the night. He was so tired. I want to thank Honorable Philip Pierre, who just received information and he said, that's good, that's good. I want to thank Nyman. I want to thank the Permanent Secretary. I want to thank them all for everything they have done and more. This whole spread, you being here at the Royalton, that's their money. Because they believe in what we are doing, and they are also partnering with us. So can you give the St. Lucian government a round of applause? I also have to thank our patron. I know that Clifford has to go because he's going to make a climb, a rock climb somewhere. But I want to give thanks to our patron, even our patron in St. Vincent, Rennie, who's going to be inducted in the Caribbean Hall of Excellence in September and also here. And on Saturday, Margaret, is going to be a great day. We are going to celebrate your son. He deserves. We are going to call his name and celebrate him posthumously. He deserves that. And he is a trailblazer. You see, I'm using the word is, not past. His work will go on. And just to let you know, we have announced an award in Margaret's beautiful son, which you will hear on Saturday. I want to thank the St. Lucian Police Band that will be performing for us tomorrow. Woo! I can't wait. So I'm excited by that. I want to thank the St. Lucian government for the wonderful police support, escort that they gave House of Lords people and myself and the others in getting here safely. I want to thank you so much for that. Have a wonderful evening. See you tomorrow and enjoy. What song we gonna sing? Coming in, coming in, coming in from the cold. Sorry, we women are coming in, coming in, coming in from the cold. We don't want the men to feel bad. We say, we men are knowingly accepted the woman. Coming. We don't think you'll be bad. How can we change it up? We say, men are knowingly accepted the woman on the road. Is that better? Oh, you have no choice. No, we have to be nice to them. Come on, we have to be nice. Come on, let's help. Okay, we come in this way. We're gonna help you. We coming in. We coming in to help the men on the road. You see how supportive we are? We are coming in. We're coming in to help the men on the road. You like that, Professor on TV? You can't say we sexist here. We are coming in. Coming in. Coming in, young men.
One, two, three, four. Stand up, stand up, stand up for your rights. Stand up, stand up, stand up for. There are only four of us here. No. Yeah. Get up. Wait, if you are of the male gender, could you stand up, please? And because you are being oppressed. And we have to stand up for our rights. So, yes, we are oppressed here. We feel oppressed. So stand up, stand up, stand up for your rights. Stand up, stand up, stand up for your rights.
So it's okay with you ladies, stand up. Stand up for our rights.
No woman, no cry. Come on. No woman, no cry. Dada, no woman, no cry. You have something to come back with? You have something to come back with? You understand? In this great future. Or do you want me to say, I throw my corn? I ain't corn no foul. And then a chuk chuk chuk. Where's the man? Where's the man? What's happening? Oh, okay. It's a man's world. Is that all right? Look at me, you know the what? Yeah. You know the anyway, guys, have a good night. Thank you. Did you enjoy that? Yeah, I'm gonna love it. For your stuff. Yeah, gonna love it. But that's just
So we're starting having you over. Actually, the Seeing that frustration. Every year, I think last year. Yeah, so last year also, they kids. So the president of the Nigerian Football Association, I have proposed from NFC. And similar this year. I'll be there. Yeah, so also, see, there's Dennis, which is, yeah, they were there last year, so they. 2000. What inside the yes. Very last. No, you put it. Yes.